Good afternoon, everybody. We're just going to give people a moment to get in, and then we'll get started. Perfect. Okay, in the interest of time, we're going to get going. I imagine we'll get a few more people trickling in. But I want to start with a big thank you for everyone for joining for the 7th annual Newborn Screening Bootcamp. We're really excited for today's event, and we have a really exciting agenda where we think we're going to really have some really fantastic conversations around newborn screening, learn a little bit more, and more importantly, talk about action items that we can do to really start to move forward and to engage within the newborn screening space. So as always, we wanted to give a big thank you to Expecting Health and Natasha Bonhomme and Mariana Rea on their team. They have been such fantastic helps as always as co-hosts for this event, and you'll see them later on today as moderators for the event. And so as always, a big thank you. I do want to start today with a few items in terms of, obviously this is a little different this year. We have been doing in-person boot camps previously, and this year we moved to a virtual format. And we're really excited about this because it provides an opportunity for more advocates to join, more advocates to participate in the boot camp, but also because we do intend to return to a in-person boot camp next year. So this kind of 2-year cycle of 1 year virtual, 1 year in person, something we're really excited for, so that we can have ways to engage a broader community in certain years while still not losing that in-person event every other year, and really get to have those conversations with each other in a gathering spot. And so we're very excited about that. We're also really excited about this Zoom platform. And so the reason I flagged that is because there is a unique feature on today's call. You'll see on the bottom, normally when you see your chat, raise hand, Q&A box, there's an additional button known as, you can see, for resources. And so what that resources tab is it provides a few documents that Expecting Health and Every Life have left there today that you can utilize beyond today's event. And so there is a lot of Expecting Health materials around their tools and how to work within the space. We have the Every Life Newborn Screening Action Center is included there, and there'll be others shared throughout the day as well. And so we're really excited for that. And to that end, we can get kicked off. And again, there is closed captioning available, as well as Spanish to English translation. Perfect. Mariana in. Great. And so with that, I will share my screen and get us started. Perfect. Okay. So again, a big thank you to Expecting Health, as always, who are fantastic co-hosts in this event, and we're very excited about that. Again, a big thank you to our sponsors, who are always extremely helpful in supporting this event, as well as a big thank you to Sanofi, who is our presenting sponsor this year. And I want to take a moment to kind of walk you through what the agenda for the day is going to look like. So we have 3 sessions. The first is going to be split into 2, which I'll talk about a little bit momentarily. But it's really going to focus on 3 main areas. Newborn screening is, you're seeing a lot more work occurring at the state level with the current uncertainty at the federal level. We're seeing more and more advocates and more organizations engage at the state level. So we want to have a conversation about kind of what that looks like and what do you need to do when going to state newborn screening programs. Following a short break, we will then focus on the role of patient advocates in research and data collection. That has long been a role of many patient advocacy organizations, but we want to ensure the fact that we have a conversation about what exactly that can look like. And then we'll end with looking forward. There's been a lot, especially at the federal newborn screening level, a lot has occurred this past year within newborn screening, and we've seen a lot of changes and a lot of proposals. And we want to take a moment to kind of take a step back, look at that, look at the context of what has happened, while looking forward. And not so we will not spend too much of that time looking in terms of resetting what has happened, but looking forward in terms of what we can do as a community to continue to move newborn screening forward. And so we're really excited about that. And with that, I'll move us into our first session, which I'm happy to moderate. And what that will do, again, it'll be in really two parts. So the first is going to be a series of fireside chats. And what that's going to do is allow us to have a little more specific conversation with our three panelists, who I'll introduce momentarily. But we'll close with a panel. And so the reason I am flagging that is because we're not going to have too much time for Q&A during the fireside chats, but we did leave an entire 20 minutes at the end for a panel that will include each of the panelists who are here today. And so if you do have questions, please do put them in the chat and put them in the Q&A box as well, so that we can see them. And then we will make sure to get to as many of those questions when we can when we get to the panel. And so with that, I will actually move to our next slide, which will introduce our three speakers. And today we're going to start with Kelly Fitzgerald, who should be joining me momentarily. But we're really excited for our three speakers because it's going to look at three different aspects of the newborn screening landscape. The first, Kelly will look at the state assembly role. Then we'll have Dr. Susan Tanksley join from the state of Texas in terms of the overall program and the lab perspective. And then Fran Altmaier will close in terms of the perspective from follow-up. So with that, I will actually bring my slides down and call on Kelly if she wants to join me in the main webinar. There she is. Perfect. Kelly, thank you so much for joining us today. If you want to take a moment just to introduce yourself, and we can get started.
Absolutely. Well, good morning, everyone. Sorry. Good afternoon, everyone. My name is Kelly Fitzgerald, and I'm the Vice President of Grassroots Development for a firm here in Richmond, Virginia, coming to you from a gloomy Richmond, Virginia today, a firm called Alliance Group. And I had the privilege of representing the Every Life Foundation for Rare Diseases here in Virginia, and working on a newborn screening bill here that we're excited to talk about today. And I've been lobbying on the state and federal level across the country for about 25 years now in different iterations. And my career has always been in rare and chronic disease. Most of my clients are in the healthcare space in some way. And so, especially with all the uncertainty at the federal level that we've already mentioned today, I'm even more grateful that we were able to pass that bill here in Virginia. So.
Perfect. Kelly, thank you so much for joining today again. It was such a pleasure working with you earlier this year. And so again, we want to start off with a general question. And for attendees, we're going to use some of the same questions over these next few fireside chats, because again, the perspective is going to be unique from each of our speakers. And so Kelly, I just wanted to open it up to you in terms of what are some ways that the state assembly or representatives engage with patient advocacy organizations as well as individual advocates, both in session as well as out of session. And so just kind of speak in terms of how that relationship tends to occur.
Sure. So first, I think it's very important, and I think that's one of the things that we want to get across today is get to know your state. The unique things about your state and your state assembly. And that can also feed into how, just like Dylan asked, how those relationships start with members. So in Virginia, our session is very short and it's very fast. We meet the second Wednesday in January, and then we go either 45 or 60 days, and that's it for the entire year. So for our state, it's very important to start those relationships with members off session when they have more time. Now, our state also a unique thing. It's a citizen legislature, so they have regular jobs. They're attorneys, teachers, insurance salesmen, small business owners, all different types of things. So they have regular jobs outside of the assembly, and then they take that time to come. So, very much, I think the first thing is where you live, find out who your members are and try and start engaging with them. You can literally just email them and ask to start a meeting. to talk about, who you are and the things that you care about. Obviously, if newborn screening is something that is important to you, that's a great way to start that relationship. But yeah, first start close to home. And they also have on their websites ways that you can kind of interact with them. Sometimes they'll have office hours. One legislator here in Virginia, every single Friday morning, was at the exact same breakfast spot for 3 hours, and you could just come by and say hi. So they also have newsletters that are free that you can sign up for on their websites and social media pages. And you can find out when they're going to be at events, when you might be able to see them out in your community. Another way, too, that I really love is inviting them somewhere. So if there is, perhaps your organization has an annual meeting or a quarterly meeting. Maybe you have an occasion where you could be giving an award away. Those are all great ways to start relationships with legislators, but I also love inviting them places if that's something that you can do too. And then in session, obviously for us, going down to the General Assembly, if there's an advocacy day you can participate in, sign up. If you want to call them and make your own meeting, you can do that too. But again, try and get to know your state and try and seek out some of that, what's going to be the best fit for you. But those are some of the ways that we interact with legislators. And then again, they're there to work for you. You're their constituent. And so it's they look to you, they need you. They don't know generally kind of what the issues are or the concerns are of all of their constituents unless we tell them. So it's also really up to us to let them know those things and to start that relationship and let them know what our needs are because they want to help. They really do. It's about, kind of communicating what we need.
Perfect. And Kelly, to that point, when talking about that communication, how is it different when either an individual advocate or patient advocate organization is going to their representative within issue? So let's say I would like you to get more involved in newborn screening versus a specific, let's call it bill. So please pass breast alignment, please pass this disease specific legislation. So
Mhm.
how does it change in terms of those kind of initial conversations and what an organization should have ready to go when they make that initial outreach?
So, I mean, hopefully, if you do have a bill that you would like to pass, hopefully you already have set the stage and you have a great relationship with a member. So then you're not kind of coming to them first saying, "Hey, we've never met before, but I'd love you to put a bill in." So hopefully, again, take that time initially to try and start some relationships with people. And that way, there are ways for them to get involved, even if you don't have a bill. Sometimes there are caucuses they can join. There might be a rare disease caucus like we have in Virginia, and I know there are some other states that have that. So you might say, hey, newborn screening is really important to me. We're not at the place where we have a bill yet, but I'd really encourage you to join the rare disease caucus. Maybe I could join the rare disease caucus and, you'd be willing to nominate me as a citizen member. There's all different ways. And also just saying to them, maybe explore, with your assembly, other ways that you can get involved. Are there other members that are already working on this that we can meet as well and sort of, join forces? So those are definitely things that you can do. If you do have a bill, I think it's always great if there is some type of kind of best practice language, because what we try and do, especially on the state level, is if there are other states that have already passed something, it's great to know what the gold standard language is because this is a very, very complicated system sometimes. And we want to make sure that the right language is there to ensure that your goals are met, and that we also, take care of the other agencies and stakeholders that we'll talk about in a second. So it is great to have kind of best practice language if you can to give to that member. Um, and then, kind of asking their advice, saying, what are some great steps that we should take to ensure that if we did put this in, it would be successful? And oftentimes they can also provide counsel in regards to that too.
Perfect. I appreciate that. And I think when also having this conversation, it's always kind of important to recognize where state representatives can not necessarily be as helpful as one might hope. So are there areas, and let's focus specifically within newborn screening, just to kind of give it a scope, are there areas where reaching out to a state representative would necessarily be setting an expectation too high that they could be supportive in a specific area?
Sometimes, yes. I think people definitely think that individual legislators do have a lot more power on their own than they do. It is still a group. And so, sure, in leadership, there are a few members in every state house that definitely have a great deal of power. But a quick story, I worked on a step therapy bill several years ago here in Virginia. It took 4 years to pass. And our member was a Republican who, at the time, they had control of the House chamber. But we did have a great deal of opposition from the health insurance company. So it did take 4 years to pass. But I remember, and this was his that with the very first year we put it in, that was his first year in the assembly. His wife actually had an issue, and so he put the bill in. And I remember he said it was the third year, and he said, "Kelly, I finally figured out how to get the bill out of subcommittee." So
Yeah.
they're learning too, in some cases. So I think it's about finding a champion who hopefully does have maybe a personal story or a personal connection, and really getting them invested. But then after that, you do need to reach out. There is a committee that the bill will go through. Normally for this, it's whatever the healthcare committee is in the state. So you need to reach out to members on that committee, and that member can help with that. But yeah, it's wonderful to have a great member. It's wonderful to have a champion, but we can't do this alone. And so, reaching out to other stakeholders, like labs that are, it's so great that we have someone who could speak to that on the call today. I think one of the really big things that we learned first here in Virginia was, first let's just see how everything is set up. What does our state lab process look like? Ours actually is split between two different agencies, so it wasn't just one agency we were dealing with; it was two. So those are all things that you can really help when you're bringing that to the member. Really flush all of that out and kind of know all the people that you need to hit, and that gives a lot of support to the member. So they're really armed to be able to put the bill in the best posture possible.
I appreciate that. And I kind of want to do a follow up on that because specifically around newborn screening, there are a lot of what I would call 30,000-foot champions in the sense of they generally know about newborn screening, they love the idea, but when you
Yeah.
ask them to describe a little bit more, they may not necessarily know more than that. And so I'm curious, and specific to newborn screening, but also more broadly, what is great information to bring to your state representative when you're kind of first making that initial touch point with them to start building their support? We like to say going from kind of no knowledge to supporter to champion. If you're going from that
Yeah.
kind of no knowledge to supporter, what is really some great information to the advocates should be bringing to the representatives?
Well, and I think that's a great question, because I think the average American, when you hear newborn screening, they're like, "Oh, absolutely, I know what that is." They don't. They don't they might realize the physical process of what happens because maybe they've gone through that with their child, but they don't understand that the federal government makes a recommendation. They don't understand that there's a panel. They don't understand how many years you have to go through, how much work and time, and how much really in-depth review goes into adding something, and that then from there we have to add it at the state level. So I think the biggest thing is to make sure that you have really well thought out information, and Every Life has some great things that you can use about exactly that process and exactly how important time is, that these new things that are added, and then again, if we are going to add them at the state level, every day that doesn't happen, there's a child who could be missed. And I find that is a really, really big touch point when you explain to them. And we had a great patient who was able to talk about their story about their child just missing it being added by a short period of time. Their child's life would have been very different. I find that is really impactful. When that gentleman was telling his story, everybody was quiet in the committee room. Like I tell, it was really impactful. So I think just members understanding that it is not a short process, that we want to work together, but like laying that out, the federal to the state. And then again, if you can have some great information already about how your state process is right now, what you're hoping to achieve. So do you have no state process and you would love to put you have to build the whole thing? Or like Virginia, do you have a really great process already? But we'd love to maybe speed it up a little bit. We'd love to, kind of do some nuanced things in these different areas. That would be great. I apologize. Of course, someone is at my door. So that would be great. And you just a second.
No worries.
Oh,
That
that's
we all in this world of Zoom have experienced that from time to time. While the dog is happily in the
Of course,
background.
there's someone at the door. Just give me 1 second. I really
Yep,
apologize.
no worries. While Kelly steps aside to handle the unexpected visitor, I do want to encourage anyone who's attending, if you have any questions, please put them in the Q&A. We're happy to address it. Kelly actually will be unable to join us for the panel. I'll myself happy to address any potential questions, but if you have any questions for Kelly,
Yes.
please do put them in the Q&A box.
I apologize.
No worries, no
Always
worries.
the way of it. But yes, so I think, those are all great things to have. And then also really quickly, just having a great list of other stakeholders that you're going to need to reach out to, the hospitals, the midwives, anyone else who might be involved. Those are all great things to have for the member.
Perfect. That kind of gets into a couple potential additional questions, but to that other stakeholders, I guess we'll start there, is what is that process like in terms of specifically within the state assembly of engaging multiple representatives? So you have interacted with, you have brought a bill to your representative, they have become supporters, fantastic. As you said before, one representative is one representative. You're going to need a coalition in any state assembly. And so what is that process like from the patient advocate perspective?
So, sort of depends. If you are a person who has, been very active in your state, you might already have, especially in newborn screening, you might already have really good relationships with your hospital association. You might already know some of the midwife associations and other things. If not, I definitely think asking for an introductory meeting would be great. Also, if you do have the chance to kind of spend some time at your state house or on an advocacy day, sometimes you can also, sort of have those conversations with people during session and sort of say, hey, I'd love to chat with you. We obviously have some thoughts about what we'd like to do in the state. We have some goals. And we'd love to talk with you about that. We'd love to partner with you. Our goal is to strengthen the newborn screening process in our state. And we'd love to talk to you about ways to do that. Understanding that obviously you have a perspective as well, and we'd love to hear about any challenges that you're having, what's going well, and really how we can work together to make the whole system work as well as possible for these families and these kids.
Um, and then probably our last question, but I'm curious if you could talk a little bit more about the relationship between state assembly and the state agencies. Now, obviously, that's going to vary a lot in every state, as well as between an individual member, and an individual agency. But can you talk a little bit about what that relationship is like, and potential roles the state assembly could be in terms of supporting interactions with state agencies? But yes, generally, just talk a little more about that kind of relationship.
Yeah. So, in your state, the General Assembly is obviously sort of over here, and then the state agencies are actually under the executive branch. So they have a lot more general interaction with their sort of commissioner of health, their secretary of health, and then perhaps the governor's office. And then we have the assembly that's kind of over here. And there are definitely some members, especially on, let's say, the healthcare committee, who have a lot more interaction with the agency staff. In our case, there's Delegate Sickles, who is the head of our House Healthcare committee. When you get to appropriations, which is the funding committees in every state, he's also the head of the Health Appropriations Subcommittee. So he has a really close relationship with the Money Committee staff, which specializes in healthcare issues. And then that member has, again, a lot more interaction with the health state agencies. So, I think it's great to encourage members to reach out to agencies and to be able to talk to that staff and learn more about it. Obviously, the General Assembly does have the power to pass a bill and let agencies know, hey, this is what we would like for you to do. But yeah, if you can make the relationship again positive and that you want to work together, I think that's always really important. And I also did mention appropriations. That's always really, I think, important to think about. We encountered that definitely here in our work in Virginia. It's easy to think that, well, maybe there wouldn't be any type of a money ask associated with a newborn screening bill, but depending on what you're trying to do and what things are in the state, there is a possibility that some funding might be required. So also that's very important to mention to the member when you're talking to them is that, we may not be sure right away, but there is a possibility. And so we want to make sure that that's always something that's part of the conversation. Again, that helps them know exactly what they need to do to help you.
I appreciate that. And actually, a question just came in that I want to make sure you get a chance to address for you.
Sure.
So I'll read it out. There are some programs that are a combination of national and state advocacy levels in play. In particular, early hearing detection and intervention, EHDI, as you presumably know, was at risk over the last several months, but is now funded as of last week. That said, how do we prioritize, balance, and approach advocacy on the state versus federal level? And so I really appreciate that question.
Yeah.
And state versus federal, I can address that a little more on the panel, but Kelly, I'm curious in terms of your perspective is how do you find that balance in terms of advocacy among multiple issues within newborn screening?
Yeah. No, I mean, I think that's a question everyone is asking right now because, before all of this happened, our, health department here in Virginia has, just been in such a state of flux the last few months as every single state has. And, in Virginia, we all generally, have been fairly slow to sort of adopt a lot of federal recommendations for many things. Virginia is more of a, well, let's see. And, so we are not a state that has a lot of things on the books where there's a state law that says every time the feds do something, we're automatically going to do it. So that definitely is something that I think a lot of healthcare advocates have historically wanted to have more in code because we want to, again, we want to make sure that timeline is there and that we're moving as fast as we can to help people. So the general thinking has been, let's make sure in the state codes that when we do these types of bills, we're putting in there, when this happens, let's automatically do it because it helps with time. But now I think everyone is 100% rethinking, do we want to do that? Do we want to retain a lot of our state autonomy? Where is that? Where is sort of the line going to be? So I think that's going to be an ongoing question, but I do think it's important to note that you need to do both. I work on a lot of access to insurance issues, and the general public does not know that there is a federal law called ERISA, and there is a portion of health insurance that is governed by that federal law. We can't touch it. Then there is a smaller portion of health insurance. In Virginia, it's about 24% of the insurance market. That is a type of insurance that we can govern at the state level. So a state bill that we pass, if it's in regards to health insurance, only is effective for 24% of our market. So that's an example. A newborn screening, I think, sort of falls in that too, is that you should never, ever just do one. Always be looking at both, always be thinking about both and be asking yourself that question. How are we interacting with each other? And do we need to go back and make a change because, something's happening at the federal level? So yeah, and if you're a state level organization, but you have a national you can connect with and talk vice versa, keep those lines open. You're both going to need each other. You both can help each other. Yeah, always be looking at both because they're interconnected. There's no way to get around it.
Yeah. Yes, definitely. Within all of healthcare, that is a lesson learned pretty quickly among all us working in the space at the connection between the state and federal.
Yeah.
I do want to flag in the Q&A, I saw that final question. I think it's a fantastic question. We will get to that in the panel. So whoever asked it, we will get to it. I did see it. But we are at our time with Kelly. And so Kelly, I wanted to give a big thank you again for joining us today and for your expertise and for all your work you've done for the patient advocacy community.
Thank you. I apologize for my talk.
No worries.
Of
No
course
worries at
that
all.
happened. But yeah, no, it's been great being with you guys. I apologize I can't stay for the fireside chat, but it's just been great to be here with you today. If you have any other questions we can answer later on, I'll be happy to do that too. And I hope the rest of your day goes really well.
Perfect. All right. Thank you so much, Kelly.
Thank you guys.
And with that, I will introduce our next speaker, who should be joining me momentarily, Dr. Susan Tanksley. Many of you are aware she is the Associate Deputy Commissioner and Deputy Laboratory Director for Public Health Laboratory Division at the Texas Department State of Health Services in Austin, Texas. Sorry for that mouthful. But Dr. Tanksley has long been a leader within the newborn screening space. She helps to oversee the public health lab, informatics, grants, and legislative affairs, as well as special projects. And she assists the lab director in managing the day-to-day operations of the public health lab. Dr. Tanksley also has previously served as the representative for APHL for the advisory committee, as it was previously situated, and has long been a leader within the space of newborn screening. And we should have her here momentarily, so just hang on with us one more moment. And again, I do encourage everyone to please include, there it is. Any questions you may have throughout the time, please put them in the Q&A for Dr. Tanksley, as well as Grant Altmaier, who will be after. We may not necessarily get to the questions in this initial conversation, but we will get to all questions as best we can in the final panel. But Susan, thanks for joining us. I'm really excited to have you here today.
Hi, thanks for having me on the panel today.
Perfect. Thanks so much. And so I want to open it up with just kind of a general question. Or what are some ways that your office currently is engaging both with patient advocacy organizations as well as potentially individual advocates?
Right, so we already do have a lot of, I guess, accessibility to patient advocacy groups as far as like contacts are concerned. So I do often get email contacts directly to me. Obviously, we've been in contact with Every Life quite a bit. And we've, through our government affairs, sometimes we'll also get requests directly through government affairs to talk, specifically about newborn screening with either single advocacy group or a group of advocacy groups. And so that already happens also through our advisory committee. So sometimes someone contacts and, they want to be able to speak about a particular disorder. And so we will put them in contact with our advisory committee so that, during those meetings, they can give public comments and start some of those discussions that way as well. So it's kind of a multi-pronged approach.
And so is there, well, I'll pull on one thread first and I'll get to a few others. In terms of, you talked a little bit around the work through government affairs, and we just had Kelly on talking kind of the role of state assembly. And one of the questions I asked her, and I'm curious from the reverse perspective, what is your relationship typically like with the Texas State Assembly? What usually occurs? Obviously, I know it typically goes through the government affairs team, but if you can talk a little bit more about that relationship and how it impacts both your work as well as your work within the lab itself, as well as how it might impact potentially your work with organizations.
Sure. So any request specifically like to speak with the legislator or anything like that, all of those things go through government affairs. So we're not allowed to directly contact legislators. But if a legislator wants to speak to us, then that's coordinated through government affairs. We have, for instance, we just received a request yesterday for a lab tour for our Senate Health and Human Services Committee. And so that's an exciting opportunity to be able to share information, not just on newborn screening, but our entire public health laboratory here in Texas. And so all of that is typically coordinated through government affairs. Our legislature meets every other year. And so we don't have that nice 60-day window. We have a much larger window that happens every other year. And it feels like we're in a legislative process all the time. But because of that cycle, It really ramps up prior to session. We just got out of legislative session. In fact, I think we just got out of a special session. So it's been about 8 months of fun. And so during the last legislative session, I was actually asked to speak because there was a bill on Duchenne muscular dystrophy going through the legislature. I was asked to speak at a morning like breakfast meeting on our newborn screening program and kind of all the logistics around it. So what is our typical, what does statute say about newborn screening, and then how is that practically implemented, sort of thing. And so those are good opportunities to also meet. I was able to meet with some advocacy groups at the Capitol that morning as well.
Great. And in terms of that relationship, if a patient advocacy organization came to you asking you to be supportive of an issue, or let's say to educate on an issue, so let's say there's an organization who's working on a specific bill and they have a state senator just is not understanding what they're trying to tell them, is it possible / allowed for if an organization then came to you and say, I would really love for you to talk to Senator Smith and set them straight? Is that something that you can do? And if yes, how does that typically occur?
So we aren't allowed to advocate for or against anything. We serve as resources for the legislature, and so whether that's in a hearing or providing information to their office, all of that would be coordinated through government affairs. So if a request came directly to me, I would point them to government affairs, and then that would be, or it came from the legislator, then they would work through government affairs, and then it would get to us to be able to provide that information, whether it's in an email or a briefing document, or directly in person. We've done all of those things.
Great, appreciate that. And to that end, in terms of how you can only engage in certain ways with the state assembly, is there any limitations, or are there any areas you're not necessarily allowed, encouraged to engage with patient advocacy organizations? Like, what are the guardrails in terms of your interaction with patient advocacy organizations?
I'm not sure what those guardrails are. I was trying to think about that ahead of time, and like, have I been told, no, you can't do this? Obviously, as I said, when it comes to the legislature, we're not advocating for or against. We're just serving as a resource. And so it's providing the factual information, and that's what we also try to do with advocacy organizations, or just singular patient advocates. We try to share the information in a way that's helpful and makes sense. So what is the information, and really trying to get to what is the information that's needed. Is this something that we may or may not be able to do? Trying to figure those sorts of things out. Even to the point of like working, so researchers aren't necessarily patient advocates, but they are working on, perhaps either screening assays, or something related to a particular disorder that may one day, when there becomes a process again for ruspedition, but trying to develop something that would be useful to put through newborn screening. We work with them as well. What is it that we can provide or that we can't provide? What requires consent versus what would not require consent? Is it something that would be a request that we could actually assist with? And that's either from a data perspective, or even newborn screening specimens, and the ability to provide those resources for like a pilot, for instance.
I appreciate that. And to that end, in terms of kind of talking a little bit about information and resources, what would you want organizations to know about working with your office as they initially reach out to engage with you?
I would say come to us first and get to know. I'm saying us, and I'm speaking for other states as well. So get to know your newborn screening program. How is it organized? people think labs, and it's not just about labs. There's the testing part, and there's follow-up, and all of that has to work in coordination. And I'm happy that Fran's going to be talking with y'all in a little bit. And that's Fran's role, is in follow-up. But speak to the whole program and get to know the program. What is the law in the state? What are the logistics around it? How is the program funded? If a new disorder was added, how would that be funded? There are upfront costs. I know that Kelly was talking about that aspect a little bit earlier about, the request. Like, you can request that a disorder be added to a state panel, but that comes at a price. And even if it's the funding piece on the back end isn't an issue, there is an implementation cost to that as well. So there's a lot of logistics around screening itself, and it's good to get to know what are the limitations of a particular program, a state, and the law behind it.
So I'm going to ask a follow-up on that last point you made in terms of limitations. What are some general examples? If you would like to use your state example, feel free. If you are aware of some broader examples, also feel free. But more curious, just again, so advocates are well aware of and what is and is not possible. What are some of those limitations you were just referring to?
So one that I would say is typical for pretty much every state is the funding issue. So if we were to add a condition to the panel, how are we going to pay for that? Not just the implementation costs, but the ongoing costs. Space is a huge issue for us, especially now. And we're very fortunate because our legislature did allocate some funding for us to be able to build additional space, but that's going to take time. So, that's another limitation, and that could very well be a limitation in other states as well. So the other thing is time. It does take time to add conditions to a panel. So once you have authority to screen, once you have funding, it still takes time. And that's something where it's hard to have patience about, but it is definitely a logistical limitation when you're implementing new conditions.
I think that makes sense, and I want to ask a follow-up in terms of, we talk often about adding condition to newborn screening, and that makes a lot of sense while it takes up a lot of our conversation. But there's a lot more to newborn screening outside of just adding conditions. So I'm curious, specific to additional communities. And so how would you interact with those? What advice would you have in terms of information to bring? And those two communities I'm referring to would be communities who work on a condition already on, let's say, the Texas State Panel, as well as conditions that know that they're a little ways off from being ready to add. So they have identified newborn screening as an avenue they want to utilize. Let's make the assumption that it is possible for those conditions to be met. They just don't necessarily have the data evidence there yet. So for those types of communities, what are some recommendations you would make to them?
So it's for communities where we're already screening for the condition. There are, we work closely with the specialists for those conditions now in our state. So if I guess, are you saying if there were issues with the current screening or just general communications?
All the above. So I know there are communities who are times or their conditions are on a panel where they would like to have conversation in terms of communication, how their condition is talked about. And I also know that there are communities who have worked hard to update the screening. And so that they view that the current screening across the country may not be as good as a newly developed test. So curious for those two types of examples.
Sure. For those, I would say, figure out who are your program directors in the state, and do some direct communication. Reach out, relay any concerns or issues that they're experiencing. because that really, if you don't know there's an issue, there's really nothing you can do about it. And if you hear from those communities and you hear the concerns, then in our case, we could reach out specifically to our specialists for those conditions and try to get even more information. We can really dig into our data and figure out, okay, what is it? It's like if we never hear that we've missed a case of something, we have no idea that we've missed a case.
Right.
And so without the communication, we can't improve. So that's what I would say for those communities is reach out to whoever it is. New Steps has program contacts on their website, and so that would be one place to start with that. I mean, the other way would be through those specialists if they didn't want to reach out directly to raise those concerns with the specialists, who could then reach out to the program as well. So and the other question you asked, the other community you spoke about, were those that may be farther away. Maybe there's this desperate need, or feel this would be great for newborn screening, but maybe there's not a population-based assay, that could be implemented yet, or maybe they're still in that treatment, trying to get FDA approval for a treatment. And I'd say engage in those conversations, start talking to the advisory committee, start talking to the various program directors. And I spoke earlier just about, we have been involved with researchers who have requests for blood spots, or trying to establish pilot studies for things that aren't on the RUSP for sure. And there are so many rare disorders I've never even heard of, and sometimes we learn about those from those researchers, or from families who've gotten in touch with us and then subsequently got in touch with like a company who's then working on an assay for that. So we've engaged both directly with the family advocates as well as with individual researchers and research groups at universities and hospitals, and that's what we've done as far as that community is concerned. But again, if you don't know the need, you may or may not be able to help as a program, but the awareness is great, and without the awareness, there's nothing you can do if you're not aware.
And final question, and again, I encourage everyone, if you have any questions, please do put them in the Q&A. We will get to them following our next conversation with Fran. But final question here for Dr. Kingsley is, what are some areas that you would like to work more with patient advocacy organizations?
I think it goes back to the, engage early in the discussions to learn about those logistics and the needs. I've had the privilege of being on the evidence review work groups, and so it's been really nice to hear more about the data, and learn more about the assays and the ins and outs of how screening works, what the follow-up needs to be, what the diagnostic testing is, and stuff like that. But those are conditions that are typically that, they're close to RUSP ready. And so I think it really is the engage early on, figure out if there's something in your state that could assist you with the process. So as an advocate, learning more about your state, how the program is run, what it would take to actually get on a state panel in your particular state.
I appreciate that. And again, Susan, thank you so much for this conversation. We will see you again soon. But with that, we want to transition to our next chat with Fran Altmaier, who should be able to be joining us momentarily. There is Fran. Fran is the manager for the Arizona Newborn Screening Follow-Up Program, where she is responsible for blood spot, hearing, and long-term follow-up. Fran is a pediatric social worker with over 31 years of experience in working with families of infants and toddlers with special healthcare needs. He has been with the newborn screening program for over 13 years. Prior to that, he spent 18 years in Part C early intervention. Fran, thank you so much for joining us today.
Thanks for having me.
Perfect. And so again, I will kick you off with the same question that I started with Susan. What are some ways that your office currently engages with patient advocacy organizations?
And I think Susan touched on a lot of what it is we have legislative liaisons. They're the main point of contact for anything really specific. But our office will meet with families, we'll meet with organizations, we can give them lab tours. I think Susan in Texas is very similar. And so that we can give them an idea of what newborn screening is, what the system of care is. And I think that's something that's really important and sometimes overlooked. And we've experienced a little of that in Arizona when we've added conditions, is people think of the newborn screening because it's part of a laboratory system, just the lab piece, and not necessarily thinking about all the follow-up that goes into after the laboratory testing is completed. So, some of the newer conditions and even early on in testing that have been tests that have been established, there's a lot of follow-up that's required on some of these out of range test results. And it requires a lot of manpower to be able to provide that outreach to the families, to the physicians, connecting to specialists. And we have a whole team that does that. And again, sometimes only the laboratory is factored in. What does it cost to do the test? And when people hear do the test, they think of just the scientist at the bench doing the testing, not the system of care that goes into newborn screening. And so I think education to the advocacy organizations is really, really important for being able to make those connections, to provide them the information that they need so that they know the questions to ask, what to do when they're wanting to advocate for additions to panels.
And in terms of those types of relationships with those organizations, how often is it your team reaching out versus the organization reaching out to you? And can you speak to both of how that may occur?
So we wouldn't reach out on our own to an organization. If they approach us, we can answer the questions that we're able to. We were able to offer, like I said, some of the guidance lab tours, maybe connecting them to the specialists. I know Susan even had mentioned connecting with the medical specialists that treat the individuals with conditions, making sure that they know who else that can help them in their quest to add something, that it's not always just the newborn screening program, but there are so many other pieces at play when you're working with the newborn screening system.
That makes a lot of sense. But to that end, and we talked a little bit about with Susan, is what are some areas that you're not necessarily allowed to engage with patient advocacy organizations? Is there certain guardrails set up? Again, this is too often, to your point, we always think of like newborn screening as the lab, but the lab and follow-up are two different teams. So is there any differences in terms of how the follow-up can engage with patient advocacy organizations, and are there any guardrails when those relationships occur?
Sure. And I can speak to Arizona and other states where the newborn screening program lives in sort of the state employee system, right? We're state
Yep.
employees, we're representing the state. And so we can't advocate, we can't lobby, we can as private citizens in our own time, but as an employee of the state, you can't. Whereas some of the newborn screening programs that are part of maybe university or hospital systems may have different abilities to provide advocacy on behalf of an organization. But as state employees, we can answer questions that we're able to answer, and we can provide some of those more sort of soft things like a lab tour, in educating them on what follow-up looks like, what happens when we are notified by the laboratory that something is out of range. This is what we need to do. When we call something out to a provider, when we have to reach out to a family because we can't find their provider and help guide them to whatever their next step is. So we can talk them through that process, but we can't, as state employees, do any kind of lobbying or advocacy work. And anything like that, we would just redirect to our legislative liaisons because that would be their point of contact. Liaison, they liaise between the legislature in Arizona and then the program. And the program sort of, management will answer the detailed questions, and then we're here to provide that support.
Perfect. And again, kind of building off of that, kind of a common theme throughout the first few minutes here is the kind of the difference between the lab and follow-up. Are there stakeholders that you engage with can you talk through a little bit in terms of the different types of stakeholders you engage with within the follow-up program and how those engagements and those relationships impact your relationship with patient advocacy organizations?
Sure. So we have really good working relationships with family support organizations. That's been enhanced as we've developed our long-term follow-up program, making sure that families are connected with resources that they need. But really, it's at the point of the positive lab test in connecting those families with the medical specialists, which allows us we have very strong relationship with our specialists. And if a family needed something or an advocacy organization needed to be connected with somebody, who do I talk to because I want to find out more about, the transplant process in Arizona? We have those connections and we're able to, do those sort of warm handoffs to here's somebody who wants to learn more to help whatever it is they're trying to accomplish, and here's a doctor who's invested in and knows what the system is and needs, and connect them.
Fantastic. And to that, and I feel like you're talking a little bit about kind of those relationships, but we know a lot of this in these situations. You have patient advocacy organizations are coming to you guys, and so in those situations, what would you want organizations to know about working with your office before they reach out? Like as they're reaching out, what information would be helpful for them to have prepared about
Sure.
themselves and what they're asking, as well as what do you think would be helpful for them to know in terms of your work itself?
Sure. So the easy part is knowing the work we do. We're happy to share what it is newborn screening does, what the lab does, what the follow-up does. There's so many things involved, but it's also we'd want them to understand that give us grace, be patient. It's an urgent need or want on the behalf of the advocate, and rightfully so, but systems do have processes that we have to work through. So if we're not communicative immediately, understand that there might be a reason and that it's okay to follow up. Hey, I haven't heard from you in a while. Is there anything new? Is there anything I can do? But give grace because things do just take time. I think the other thing that is left out is that they need to understand the whole process. I feel like advocates and organizations that I've worked with in the past, they sort of understand a bit and run with it, and really taking a step back to ask more questions or follow through the whole system of care from a sample collection, how it gets to the lab, how the labs get it into the instruments, how they result it out, how all these things have to work together to make a newborn screening result possible, and really understanding all of that. I can't remember if it was Kelly or Susan that touched on that there's just so much involved in what a newborn screening is, and maybe you've had a child and had an experience of what it is, and if the test comes out normal, you never know all of these things. And even when you're identified with a condition, you may not still understand all the things it took to get that test result to happen, from, the hospital knowing what to do, the courier to get it, the testing that occurred at the lab, how they result that out to the follow-up team, how we have to find a physician to report that result to, connecting them to a specialist, all of those pieces, and all of those pieces our time and money, and understanding that, it costs a lot sometimes to add these tests, which might feel pretty plug and play or easy, but knowing the whole system. And I would really stress for advocates and organizations to really just get to know your newborn screening program in your state, meet with them, follow the process, like I said, tour the lab, make connections. I think that would be really helpful.
And to that end, is there any area in which you would love to work more with patient advocacy organizations?
Mm, that's a tough question. Again, I think I go back to, as a
Yeah,
state employee, that's really, really hard.
fair. Yeah,
As a
that's fair.
social worker, that's my favorite part, talking
Yeah,
with families, working with them, and bringing them in to understand what we do. That's what I love to do, is talk with the people.
yeah.
But it's balancing that with the reality of government systems, and working within the sort of the constraints of what we're able to do.
Um, and then, so I guess taking a step back to in terms of interacting with various advocacy organizations, can you talk about in terms of the difference in interactions between, and this I talked a little bit about this with Susan, the kind of three buckets of patient advocacy organizations within newborn screening. Patient advocacy organizations who have a condition on the RUSP or on your state panel, uh, conditions that are not yet added, but either have the data or believe they have the data
Mhm.
to add the condition, versus condition communities that want to utilize newborn screening but are still kind of in that data collection evidence process. And so kind of how do your interactions with those various parts of the newborn screening community differ? And what is some important information for you to know for those communities to bring to you in some of those initial engagements?
Sure. And I think the biggest one, and Susan touched on it, was with understanding missed cases. For those conditions that are already on a newborn screening panel, know that we don't forget about them. There are work groups and things speaking up nationally about, let's not forget the longstanding conditions. We feel like they've been around for a long time, and everything seems to be going well, but you still need to address, are we still finding the families? Are we still identifying? Are there new tests out there? So, continue to make connections. Again, working with specialists to identify any missed cases, provide opportunity to really work through what happened. Was there any way to identify that baby with the system we have? And newborn screening is just that, it's a screening, and we know that unfortunately babies do get missed, and that's just a part of screening. But know that we still address and reach out and partner with state programs to support families to know, are there other needs out there that maybe they could be advocating for newly conditions that are just recently being added. Arizona is a RUSP-aligned state. And so when there was a RUSP, that was a really big deal. And one of the questions we had was, okay, what will happen then with advocacy organizations who want to push to add something to the panel that's not on the RUSP? That was sort of the ideal way, was to be RUSP aligned. And with or without the fall of the RUSP, it still remains, what if somebody wants to add something that's not on the RUSP? How does that happen? And how does that make sense given RUSP alignment? And then my other thought for advocacy organizations for things that are maybe coming down the line are really taking a step back, and maybe this is a personal Fran opinion, not a state opinion, is take a step back, and is newborn screening the place for that test? A lot of times, because it is such a well-oiled machine, newborn screening, and it's a system that's well known, people feel, oh, you can just do it through newborn screening. But is it better pushing for it to become a standard of care test for a newborn at a hospital versus adding it to the newborn screening panel? Because if you think of newborn screening as that system of having a treatment available, identified during a latent stage before symptoms, are we doing it justice putting it in the newborn screening system when you could really do it as a point of care test? I feel like CCHD is an example of that. It was a standard of care. Most states are just doing surveillance. And how does that really fit into the spirit of what newborn screening is? So I think thinking outside the box a little bit and working with some of the hospital and healthcare systems to really look at system of care versus newborn screening, and where do we support each other, where do we overlap, and where are we really two different systems.
It's really helpful. I appreciate that context, and I appreciate you kind of walking through those three different communities. Going back to kind of that middle, somewhere between the second and third community, but let's say a community is gathering the data and they can see the light at the end of the tunnel, where they have a population-based screening test, they have a therapy, and they come to today's boot camp and they recognize that follow-up is a key and part of the system, that we have to view it as a full system, not just a test itself. What are some ways, and then they reach out to either you or their state follow-up coordinator, what are some ways that you would encourage them to kind of conduct that outreach, if as they're starting to build up, what will follow-up look like for this condition?
Hmm. I think any state program would probably welcome at least the conversation,
Yeah.
making the connections, making sure that there's family support available for anyone identified with the condition, but also understanding bringing on tests with false positives. What is the impact on families where it's negative and the family has had to go through this whole newborn screening diagnostic process for something that maybe um, was brought in too early, or the testing isn't refined enough to have a smaller false positive rate. I think we struggle with that. We see conditions. My follow-up team works on things where it's constantly we're reporting these out, alarming families, and they're negative test results ultimately. We do that because there's a positive in there and we want to make sure that they're identified, caught, and supported early. But on the flip side are all the families who've had to go through the diagnostic process where it's negative, and what's the impact on on the family and their bonding with their newborn and all the things, the expenses, the things that go along with it, and sort of being mindful of that, I think is really important.
Perfect. Uh, One closing, right before I ask Susan to join, so I'm to the backstage of Susan wanting to get ready to join us momentarily. Fran, are there any kind of closing thoughts you had in terms of recommendation thoughts in terms of two patient organizations reaching out and working with follow-up programs? Again, too often we talk about newborn screening as just a test and a therapy.
Mhm.
And we don't want to lose sight of the fact that the follow-up is so key in that process and plays such an important role. Because again, getting a result and having a therapy is great, but if you can't connect those two, which is what follow-up is,
Mhm.
we're missing a key part there. And so,
Absolutely.
what are some final thoughts in terms of interacting with patient organizations and kind of recommendations you have for them?
Um, I feel like this is the easiest part because follow-up teams are people, and so reach out, get to know us, learn what the follow-up process is, but also learn the whole system. And I think I've already said that where understanding the entire newborn screening system is really important in making sure you're not short-sighted on any step along the way, because there's so many pieces. People talk about the lab, the follow-up. but they don't talk about, and I touched on this, the hospitals, the couriers, the demographic teams that have to data enter everything, the billing systems to help us pay for these things. I think there are so many pieces of it that that aren't always addressed, and just make sure you understand the whole system of care.
Perfect. I appreciate that. And so with that, we're going to move into our kind
Yeah.
of Q&A panel. So Susan, if you wouldn't mind joining us. But to that end, one of the questions I wanted that you brought up that I actually wanted to ask both you and Susan, so I'll start with you first as Susan does join us. You talked a lot around kind of knowing the systems of kind of a state program. So could you talk through exactly what exactly you mean by that and some of the differences? And with Susan here, she can kind of talk about that as well from the lab perspective. What some kind of are those systems that you're referring to, and how does that change, and how do the interactions change based on kind of who you're working
Yeah. So, and I guess the systems in the sense of all the touch points of a newborn screening sample would be the biggest thing is understanding, the design of the cards, or the getting cards to the hospitals to collect, training hospitals on how to properly collect a sample. You need educators to be able to do that in your newborn screening program. Courier systems to get samples from hospitals or midwives or pediatricians' offices. Susan and I are both from 2 screen states. Second screens are collected at pediatric practices or labs. How do you get those to the state lab? How does the information get into the system? Not every state has a great information system, and some states still have people manually data entering. Some states are far ahead and have, electronic messaging to get results, but you have to get that sample to the lab, into an instrument, tested. Lab scientists have to review results, then they have to call it out to a follow-up team. We then have to find pediatricians and sort of, play detective sometimes to locate a family to even get them where they need to be, and then connecting them with the specialists. And then it all has to be paid for. So, you have to have systems for billing, whether you're selling the cards up front or billing after the fact. There's just so many steps in the process, and advocates need to understand all of those, how they interact with each other, and that there's a cost for all of that to be able to run efficiently and effectively.
Susan, anything you would like to add? If not, happy to move to the next question.
I think Fran covered it. It's the screen is a tiny piece in that whole time frame, and it is important in that it provides results, and you have to have a good sample to be able to get those results. But the whole child's life is after that, and so it requires those systems of care to be able to do something with those newborn screening results to have a positive impact on the child's life.
Appreciate that. Okay. With that, we will get to our Q&A. We have a few in the chat, so I will read them off so as well. And again, I do want to encourage people to utilize the Q&A. I do have a few here, but we want to hear from you guys. So one of the questions here, I'm going to rephrase a little bit, is we know the industry plays a role within newborn screening. Within the therapy development space, they as well will recognize the importance and impact of newborn screening. And so we know that biotech plays a role within newborn screening. So from your perspective, both within the lab and follow-up side, what is your perspective in terms of industry's role in advocating for a condition that they have treatment for within newborn screening?
Susan, you want to take that?
That is a tough question. So I think from a newborn screening program perspective, and maybe this is one of those where, like Fran said, maybe I'm speaking for myself, but the way Fran mentioned earlier in her response about, maybe not everything has a place in newborn screening, and by that, that whole piece, like in the evidence review process of does the newborn screen, having an answer at the time of a newborn screen, actually impact the outcome, which is a really hard part of the evidence review, a hard question to answer. So does having a result pre-symptomatically make a difference in the outcomes for that child? And so as a newborn screening program, that's a piece that I cling to as far as, does a result really impact the child's life? So is that a condition where having an early pre-symptomatic answer make a difference in the child's life? And if so, is, that's a condition that would be more in the, okay, we think this is a proper condition to add to the newborn screening panel. Industry has a huge role, because without industry, you can't have some assays. We do have lab developed tests. Not all states are allowed to use lab developed tests. And so that makes it hard when there are conditions where there is not an FDA approved test kit. So speaking from just the logistical piece of screening for a condition or not, there has to be a company out there that's willing to, make that investment. And treatment wise is the same way. If there's not an effective treatment, well, then what is the purpose of screening itself? So as far as like our roles around that in the program, again, it's more of from my perspective, once something is either on the RUSP, as we're a RUSP-aligned state as well, we're trying to figure out how do we add that to our panel. But again, as Fran said, we can't lobby for things. On our own time we can, but not as a representative of the state. So it's really a fine line we have to walk in regards to working with companies.
Yeah, and I'll just add that, it's the same with a family or a company. Is if we can't answer, we might be able to make a connection with them or for them to somebody who can help and answer their questions, or sort of, carry on their mission with the testing or the treatment that they have available.
Thank you. I appreciate you guys' thoughtful response there. And to that end, I will take the next question because it's more on the legislative side. So I'm happy to address that. So there's a question in here. What do you advise when pushback against the bill is from medical providers and other medical organizations? Though they know what's in place is not enough, they have an issue with a parent advocacy nonprofit proposing the bill. There's a lot within that question. So if it is just an issue with patients getting involved, that's a harder question to answer, because the organization that has that perspective, if they're just frustrated that patient advocacy organizations are getting involved, I'm not sure you're going to be able to necessarily convince them out of that stance. With that being said, if that is what is occurring, maintaining that relationship, a strong relationship with your state representatives and state senators is really key, because they know that patient advocates have a role in the legislative process. They rely on their constituents, they rely on the patient advocates, they rely on your organizations to help them provide the information they need and identify some of the solutions. I don't remember Arizona's legislative calendar off the top of my head, but we've talked about two very unique sessions in terms of Texas every other year and Virginia having short windows. Kelly talked about how they have a 6-day legislative window. Some years they have a 45 legislative window. So when you have that short of window, you have to rely on external groups to help flag what is impacting their communities. And so from that perspective, just maintain that relationship with your state representatives. If the question is more of they don't have an issue with the role of patient advocacy organizations, they just believe that what you're advocating for is incorrect, still not great, but that one's a little easier to address. That is just more of engage them in conversation. go to them with why you believe this is the time to advocate for this legislate for this issue, and go with an open mind as to what their objections are. You may, at the end of it, disagree with them, and that's fine. And if you disagree and they have not convinced you of their perspective, continue to work with that state representative. But go in with an open mind, engage them in conversation, because inevitably, newborn screening is the definition of a nonpartisan issue. I have worked on RUSP alignment in 9 states, I believe, somewhere around there. I have had a variety of arguments proposed to me in terms of against the legislation. None of them were made in bad faith. They were all had real concerns about how the bill could be implemented and how it could impact their state. And so you want to sit there and have those conversations and hear them and see what they're saying. Sometimes you can make some changes to the bill to accommodate those changes. Sometimes they're just going to be disagreement, and that's okay. But as long as you go in with that open mind, that was really impactful. And an example I can give, actually, it was in Virginia this year, is there was some concern around the timeline that's included in RUSP alignment legislation, and there was some worry around part of the process that was outside of their control. And that is something that we've actually heard in previous states, something we actually worked with in our Wisconsin bill as well. And so that was something I was like, hey, we can work with that. And so we were able to kind of move around the timeline to ensure the fact that what was in their control was under a certain timeline, and what was outside of their control was not necessarily tied to the timeline for implementation. And so you want to have those conversations. But I appreciate that question. Fran, Susan, I will now come back to you. And again, I do encourage anyone else who has a question, please drop them in the Q&A. So the question is, how can we find more information on the processes for adding condition in each state? I know few have forms on their website, but I know there are a variety of other ways. So Fran, Susan, if you both could talk a little bit in terms of where to find more information about the process for adding conditions in your states.
You go first, Fran.
Because that's a tough one. I have absolutely no idea. So, the easy part is we're RUSP aligned, and for whatever that looks like in the future, the hope is that if something's added to a national panel, we will follow suit and add it within the 2 years, which is what our legislation is. But ultimately, it's up to advocacy organizations to introduce bills each legislative session for what they want to propose. And I think we've touched on this is, plan ahead, know what it is, know what the timelines are, what's available, who the people are. Work with the legislative liaisons. On our website, I'm sure it's accessible, who our legislative liaisons at the Department of Health are, and work with those people. Understand your legislative process. I think that was really important that Kelly, shared at the beginning, was know what your state sessions look like. We've heard 3 different types of legislative sessions. Arizona, every single year in January, it opens up and it closes by the end of June. But know what your state's process is. Reach out and find out.
And I would add, you can reach out directly to your state representatives, so newborn screening program representatives, because they will know what the law is in their state, what the process is, that sort of thing. So if somebody contacts me, I will say, our state is required to screen for conditions on the recommended uniform screening panel as funding allows and as space allows right now. So that is, it's kind of like, here's the law and here's the logistics behind what we can or cannot add right now. In addition, the law allows for our advisory committee to make recommendations. And so therefore I advocate for them. I give them the contact information for the person who does our advisory committee coordination, because she can tell them when the next meeting is, how to sign up for public comments, that sort of thing. So how do you, if it's not me or if it's not Fran, how do you get in touch with us? Well, New Steps has a great website. I use it myself. I don't know who every program contact is. I don't have all of their contact information, but I know I can easily go click on the state, figure out who that is, and get their contact information. So I would advocate for, getting to know who the program representatives are in your state, and you can get contact information from the New Steps website.
All right, so a question came in that we're going to ask. I will say to the person who asked, I'm going to adjust it slightly, but I hope to still get to the core of your question. So it was around the RUSP, but I want to broaden it a little bit and also provide a question, a different way to ask that question. So we will talk more about this in our third session in terms of some of the recent challenges at the federal level of newborn screening. But they did specifically curious about the perspective of both of you in terms of, from my perspective, building off of their question is, how has the upheaval, I guess or uncertainty is probably the nicer way to put it, at the federal newborn screening programs impacted your work? And in addition, how has all of that changed your view of the RUSP overall?
Well, I'll start. So first of all, the RUSP is a panel that's endorsed by the Secretary of Health and Human Services. So the RUSP still exists, and that's the way we look at that. And right now, we don't know what the process is to change the panel, except we do think that the Secretary could change the panel. And so at this point, I know there are some different efforts going around looking at DMD and MLD right now, and the evidence that the evidence review work group did work on both of those conditions. And I know that that information has gone forward both to HRSA and then through ACMG. There's been some discussions, and also, Every Life, you guys just put on something last Friday. So how has it changed our perspective? So for Texas specifically, we have a newborn screening preservation account, which is like a savings account, and it can only be used for implementation of new disorders and a couple other things. But it is specifically stated in our, as part of our law, that it can only be used for implementation of conditions that are on the RUSP. So Duchenne muscular dystrophy was just added to our panel in Texas, but it's not part of the RUSP. And so because of that, if we had the space to add it right now, we would have to utilize other funding. We wouldn't be able to use the preservation account funding. So that's a very specific, Texas specific implication of having the condition on our state panel that is not on the RUSP.
And I would say for Arizona, it's kind of watchful waiting. We're just kind of at a pause. I don't know that any decisions have been made because it's still so new and there are so many things happening, nationally that we're continuing to operate under the status quo of the conditions that are currently on the RUSP as we knew it, and testing for those and working to bring us up to the full panel within the timeframes set out in our legislation.
Thank you. So just last question in terms of any final thoughts. Again, we really appreciate both of you joining us today. I think it's been really helpful for those on the call to kind of understand what how your engagement looks like with patient advocacy organizations. But in the last 90 seconds, if you guys want to share any final thoughts before we head into our break.
I'll just end by thanking you for allowing me to be part of the panel, and always open to sharing information with anybody who contacts me.
And I'll echo the same, thank you for inviting me. And like Susan said, the New Steps website has all the state profiles available on it. go to newsteps.org, look at your state, and see if you can make contact with the newborn screening teams where you live. Thank you.
Perfect. Again, thank you both so much for a fantastic chat, a fantastic panel. We really appreciate all the work that both of you do. And to that end, we're going to take a short break before we get into our final two sessions of the day. And so we will be back at 1:40 for our next panel. Thanks so much. we are going to get started. We're going to get started in approximately 1 minute. So if those who are still with us, we'll be getting started momentarily. Okay, I see everyone's starting to come back. We're at 1:40. And again, thank you so much for everyone for staying with us. We're excited for our next session. And with that, I will move it over to here. We're excited for our fantastic panelists, and Annie Kennedy, our Chief of Policy, Advocacy, and Patient Engagement at the Foundation, will be moderating this panel. With that, I will pass it over to Annie, pull this screen down, and let you guys get started.
Great. Thanks so much, Dylan. So I have the honor of moderating a really terrific panel discussion where we're going to explore and dig in a little bit to the role of patient advocates and other stakeholders in research and data collection. So I'm going to do introductions of our esteemed panelists. And then I've asked each of our panelists to spend just a few minutes really teeing up this discussion by explaining what their role and what the programs they represent have been doing to really move newborn screening programs forward. So first, I'm going to do it in the order that people were on that slide. We ordered this. First, Catherine Anderson is the Community Research Manager for Data Initiatives and Advocacy at Parent Project Muscular Dystrophy, or PPMD. She graduated with her master's in genetic counseling from the Johns Hopkins NIH training program in 2019 and was a researcher and clinician in Vanderbilt's Division of Cardiovascular Medicine before joining PPMD. She supports PPMD's initiatives to expand newborn screening for Duchenne muscular dystrophy, including collaborating with clinicians, researchers, industry, and patient community members to collect data to inform the completion of the Duchenne nomination package and what we hope will soon be the implementation to the Recommended Uniform Screening Panel, or RUSP. Next, we have Dr. Wendy Chung. Dr. Chung is a clinical and molecular geneticist. She's the chief of the Department of Pediatrics at Boston Children's Hospital and the Mary Ellen Avery Professor of Pediatrics at Harvard Medical School. Dr. Chung has identified the genetic basis of more than 60 rare diseases. She leads the Guardian study to expand newborn screening for genetic disorders and advance the development of personalized therapies for children with these disorders. She's received the NORD Rare Impact Award and is a member of the National Academy of Medicine and the American Academy of Physicians. And then Dr. Karen Albeck is a professor and vice chair for education in the Department of Biomedical Informatics at the University of Utah. Her research focuses on genomic data science, clinical informatics, and the communication challenges in newborn screening. Dr. Albeck has led multiple NIH-funded projects to advance methods for genomic data interpretation and has been a strong advocate for improving how complex genetic information is very importantly communicated to families. So thank you very much all for being here with us. I think let's start with Catherine. And Catherine, if you could take us through just setting this up from the perspective of a patient advocacy organization, just sort of tee up sort of the creation of the work PPMD has been doing in this space. And for the sake of our question, the panel, we'll get into more of the data collection, but maybe you can just sort of frame the infrastructure work you've been doing.
Sure, absolutely. So I'm sure as many of you are aware, the ask on data for newborn screening is in many ways quite broad and quite deep and relies on the resources of so many different partners and collaborators to grow and be effective and really inform that work. And PPMD has been involved in this in a great many ways. Some of the, and I will admit too that I've been with PPMD a little bit over a year, so some of this was before my time. But some of the big pushes that we've been involved in include supporting and in part funding the New York State pilot for Duchenne newborn screening, which involved collaboration, a wonderful steering committee with collaborators from the state lab, clinicians and researchers, including Dr. Chung, guidance from other newborn screening conditions, industry, expertise from the Newborn Screening Translational Research Network and BSTRN, so some NIH and some ACMG guidance, which involves a great deal of coordination and collaboration and working through what systems need to be in place for this to be smooth and effective, what consent looks like, what the handoff looks like, a great deal of time, energy, effort. And then as our nomination was coming to a close under the original process when we were expecting a vote in this spring, we had been asked to do a final push for data showing the impact of early intervention on Duchenne outcomes. And as part of that, we organized an early intervention virtual symposium. So with a leeway of about 7 months, reached out to, again, our research partners, our industry partners, our clinician partners, our advocates who contribute to our natural history registry, all of these teams that could do that big final push for data to access different types of data that could be presented to inform that question, and ended up with 9 abstracts that were accepted through our peer review and were presented in that symposium, which was about a month before ACHGNC was dissolved, but has still been very useful data to bring to the conclusion of this decision as we move through, and to bring to states as we're talking to them about newborn screening.
Thank you, Catherine. We'll dig into some of what those data collection efforts were and how you did that in just a moment, but thank you for setting that up. So Dr. Chung, can you talk to us a little bit? I know you've been engaged in a lot of different efforts, but can you help sort of shape your role in this ecosystem for the sake of the conversation?
Sure. To me, this started out in 2015 when we did our first pilot in newborn screening with SMA. And we went from SMA, that was successful. We actually partnered with PPMD with Duchenne muscular dystrophy. And I guess maybe in part it was COVID, maybe part I could see how long it was taking to do these one by one with pilot screening or pilot programs. And I said, we've got to think about this more holistically when it comes to rare diseases, and hence the idea, which I was not the first, just to be clear, in terms of having genomics as a platform to be able to think about this, but we really started to get serious about it. So with doing that, we actually went back to our participants who were quote unquote normal, parents of normal infants in the SMA pilot study. So we started with them in terms of they really designed Guardian, and then thinking about that, brought in the rare disease community to think from their point of view, both in terms of what to include, what not to include. And within this, it may get to some of the questions the audience has, which is what are the criteria for what we put within the platform? So if you do in Guardian, we recycle, we reuse the residual dried blood spots, so we don't do anything extra. We do whole genome sequencing from that. It's a consented research study. It costs families nothing to do this. And within this, even though we do whole genome sequencing, we don't look at everything. So the critical question becomes, what do we report out in terms of what conditions, and even within what conditions, what variants do we report out? And in doing this, it really was that ecosystem, which took many, many cycles and focus groups in terms of being able to understand the complexities. And in doing this, we wanted to make sure that we were not leaving anyone behind. And so in doing that at the variant level, just to be really clear and somewhat technical, we did make a strategic decision to be able to be inclusive because treatments were available and would be helpful, to be more sensitive, not perfectly sensitive, but to be more sensitive and lose out on some of the specificity, knowing that we would have some false positives, but try and balance that so that we were not leaving children behind in terms of access to care. So within this, I'll just say that I'm humble enough to admit that I'm not perfect. And so we literally go through on a week by week basis, if you can imagine it, iterating and improving everything we do within Guardian. Within that, we had version 1.0 of the test, which was by my own sort of requirement, relatively constrained at about 250 conditions, just to make sure we could do this and not fall flat on our feet in terms of being overwhelmed with anything in the process. Once we knew we were able to do that, we almost doubled and went up to 450 conditions during this intervening period. So during the first year, as we were letting the community know that we were doing this, we had and have an open call. So for anyone who's listening, you can go to the Guardian website. We take nominations from anyone in the community. I can say we've had over 100 nominations from patients, families, providers, scientists. It comes from, as far as I can tell, really everywhere, with a very simple application process. It's literally an Excel spreadsheet with a few fields that people fill in to then help us go through we do it once a year, go through nominations and think through really what, from a technical point of view, we can add, what we have capacity to add, and then from a clinical point of view, what meets the threshold in terms of treatability. On that last point, I'll say, and again, I think I'm not claiming that we're the only reason for doing this, but this has caught on internationally. And so there are now a couple dozen different similar programs around the world that are doing some sort of at least DNA sequencing, if not genome sequencing. And we are coming to some consensus, at least in terms of core conditions, which is good. I think we're sort of making ourselves think critically about what are the criteria for doing this. But this does become a critical question. And I was also on the National Academy of Medicine, the NASM group that published just recently some of the thinkings on newborn screening, and in a good way, CZI actually supplemented what we were doing with having engagement from the rare disease community that I found quite helpful in terms of making sure that voices were heard. And within this question about what is treatable enough to be able to be on, I think becomes a really critical question. And so I'm just going to underscore that because I do think it really is a critical question right now. We've been, and I will say I've been trying to think about this because we get data back from our participants 1 month after we disclose. And I'll say, just one more point. We don't just do the screening and then disappear. Within Guardian, we do the screening, we confirm the diagnosis, we onboard to care, and we have a whole team of people supporting the families through that process. But again, just to remind you, I made the decision to suffer specificity at to be able to enhance sensitivity. And so we've had the experience of having some false positives. And so it's been really important for us to, as we get better at this, know and set expectations about whether or not, even though it's a screen positive, whether it's likely to be a true positive. We've gotten much better at that. And so I can set expectations. But also the thing I've observed is that we've had, some people know the study, 2 groups of conditions, and I let parents choose their own adventure. So group 1 conditions are ones that are very treatable, very acceptable, accessible treatment, very effective treatment. And in general, the support from that, having done this now for 3 years and 20,000 babies, so a fair amount of experience, overwhelmingly positive in terms of that. We have also, though, included some of the what we call group 2 conditions, which we had defined them as being increasing the chance for having epilepsy, with the idea that treatment of epilepsy would improve outcomes. But still, some of those conditions might be associated with residual neurodevelopmental issues that might benefit from other, whether it be early intervention, treatments of associated medical conditions, but they weren't necessarily cured. And so we've let parents choose their own adventure in terms of whether or not to elect to do those. Overall in Guardian, about 74% of parents have decided to do the study, period. And of those parents who decide to do the study, about 92, 93% decide to do everything, both the optional module and the course. So we've let parents vote with their feet. However, I will say in terms of doing this, I have been watching, there are not very many, but there are a few parents that have, they're adjusting to the diagnosis. I think that's true whether the diagnosis comes from screening or it comes from after a child is symptomatic and gets genetic testing in a diagnostic mode. I think there's an adjustment period, but I'm very sensitive to what that's doing with our families and whether or not, especially within false positives, if I can't entirely get rid of false positives, or if I can't get rid of the vast majority of them, this balance between sensitivity, specificity, what you put on the panel, and again, what that threshold is in terms of how much good you can do, and then also trying to balance setting expectations, being accurate in the prognosis with this. So the point that I'm trying to, just air every bit of dirty laundry we have to try and get community input on this is that there's a balancing act that you run within these, and they're very conscious decisions you need to make. But the wonderful thing is that you can iterate. And so you can learn and you can make adjustments and you can learn from that process. I don't mean to say that any of the parents are, part of some grand experiment on them. We're trying to help their kids and more importantly, help the whole next generation of children growing up. But I do think it's incumbent on us to be very careful observers and be willing to iterate and make adjustments as we see what the data are coming in from families about what's acceptable and how we can improve.
That was an amazing setup. Thank you, Dr. Chung. We'll come back. Let's dig into that a little bit more because I know Catherine has also collected some data from the community, but I want Dr. Albeck to be able to come into this conversation too, because I think you just gave a beautiful segue for her introduction. So Dr. Albeck, please introduce yourself and talk to us about what you do.
So I'm a bioinformatician, and I've spent most of my life in diving into genomic data. So I feel like my training is very abstract. I didn't deal with people until very recently. So I have built knowledge frameworks to be able to categorize different kinds of genomic sequences and variations. I've been heavily involved with ontology building, and that's very far removed actually from newborn screening. So a few years ago, just before COVID, one of my PhD students graduated and she moved to the state lab. And her role was to start building pipelines for exome sequencing for very few genes in the set of tests that happen in Utah. And because of this, I got introduced to the lab director and got involved with the pipelines and the implementation to make the secondary testing interpretation pipeline work better. And it was a nice project, very real, very hands-on. And when that finished, the lab director asked if I would help them do an exploration of where things go wrong. And so I've never done qualitative research before. That wasn't in my bag of tricks, but I knew people who could, and so we set about learning how to run studios, and we met with parents and tried to figure out the pain points that were happening in the follow-up of when someone gets a newborn screen result back. And that was really, really motivating. I think meeting parents and really getting to grips with when things go wrong, like the horrible things, changed the focus of my career somewhat. So I've become quite invested in building informatics tools and in implementation that will help parents navigate the newborn screening process. So we have developed, working with the follow-up team and genetic counselors and parents, we've developed chatbots to help explain results for at the moment for trait results that are given back by the state to help bridge the gap between receiving the letter that says your child is a carrier for this disease to actually seeing the pediatrician or seeing a genetic counselor. And where I think this work is leading us is the chatbot was really well received, and when we studied like parent reactions, there was a decrease in distress and anxiety as they got the result and then used the chatbot. And I think going forward, one of the issues that my lab would really like to address is explaining what newborn screening is in the consent process. So in Utah, the legislature got involved again with newborn screening this session, and there's been changes. So parents now are having to consent to data storage and sample storage, and the mom is actually consented as she comes into labor and delivery. And so we're hoping to be able to actually provide education through a chatbot that provides them with the information that they can then give actual informed consent. And so we're building that chatbot out now, and the computational person.
I'm intrigued. Okay, so thank you for, first of all, I just want to say from the outset, thank you for the work that you all do day in and day out on behalf of all of us who are a part of this community. I also realized I never introduced myself. So for those who are watching today who are new to our community, I'm Annie Kennedy. As Dylan said at the beginning, I'm with the Everylife Foundation. But for context of this programming today, I've also been with the newborn screening community for a couple decades. Prior to coming with Everylife, I was part of several of the newborn screening communities we've been talking about here today. So I helped build the infrastructure for the Duchenne newborn screening program and worked with the SMA newborn screening program. So these are near and dear issues to my heart, having come from patient communities that helped develop some momentum for these programs. So maybe I'll dig in a little bit. We touched on so many different issues, and I think the sort of the undercurrent of all of this that I feel like is very important to say is that much of this momentum is driven by patient groups from the outset. And one of the things that I wrote down, well, Dr. Chung, while you were speaking, is it costs families nothing when you were talking about Guardian. So I think one of the things I just want to sort of say is that all of what we're talking about, though, has funding implications. And especially when we're talking about consenting versus not consenting, building new technology, doing all of this research, data collection, there are just funding implications behind all of this. So we can circle back to that, but I do think thinking about who are the stakeholders, where are the funding resources, how do we ensure that the data collection, the research needed to collect evidence, but then most importantly, all of those follow-up programs and wraparound services are funded, that all of that exists and that there's incentives to ensure that that exists. So I just wanted to say that from the outset. We can come back to that because my question to all of you is who's funding all of this work? And we'll circle back, but I'll just put a pin in that so that we can have the full conversation. Can we talk about what is considered treatable? So Dr. Chung, you talked about treatment and that you do an open call for nominations based on treatability, and that's something that the National Academy has wrestled with. Can you talk a little bit about that? And then Catherine, I'd love to hear you talk about that, as that's something that I know has come up in the evidence review.
Sure. I think this is one of the biggest pain points when you think about and I think this has evolved a little bit over time. When you think about the classical sort of Wilson and Unger criteria for what should be on public health. And let me just say very specifically, I'm talking about public health newborn screening. So these are public health dollars going towards this and for funding and support this. I think the community in general, the academic and then the RUSP had thought of a very high bar, that this is something that really is extremely well treated, that there's extremely good outcomes with treatment, in other words. And even some of the other programs in the UK, for instance, if they've been doing theirs, I think they've had a similarly high bar. I have to say that, and I don't think I'm being naive because I feel like I've been doing it this now long enough that I've seen what's happened to even some of my patients that have grown up and gotten earlier diagnoses. And as a community, how we've learned, I call them tips and tricks, but we've learned things from each other about how to be able to anticipate problems, get in front of them, everything from medical issues to supporting families, just to know what to expect, to educational strategies, to be able to let every person be their best selves. And I really truly think I've seen an improvement in outcomes for many conditions, but it really does matter with earlier diagnosis. And that in part is avoiding some unnecessary, ineffective, even potentially harmful treatments until you get to the diagnosis. So I tend to be I tend to be more liberal in terms of that treatability and improvements for outcomes. But I do think, and I understand in terms of putting resources into this, that definition, like I said, people are holding a very high bar from a public health point of view. And I think we need the evidence. I think we need the data to be able to change hearts and minds. I think we need to demonstrate what to me has felt more like my clinical intuition, but demonstrate it with data. It has to be on a case by case basis. You can't just say all conditions are the same. I think we have to be able to make, I mean, I don't mean to put it in dollars and cents, but I think you have to make in part an economic argument in this in terms of that. I think you need to put quality of life and for parents, what that means for them. And I think if you do this holistic view of things, let's follow the data and see. But I do think, people want to make sound evidence-based judgments in doing this. And I think as a call to action, that's one of the things we could do as a rare disease community. And I think there are some ability, and I think your organization is one of them, Annie, in terms of helping organize across rare diseases. And just to say it out loud, you guys have done a great job in terms of thinking about some of those analyses.
Thank you. So can I just break that down just a little bit more? Because, who's listening today, we have a lot of patient advocacy organizations that are in this space or some just entering the space. We have industry partners, other academics working in the space. So as you sort of look at applicants who are considering wanting to be added to your platform every year, is there criteria that you're thinking about for treatability? Are you looking at, does the condition have an ICD code? Are there clinical care standards? Are there outcome measures? Like how are you thinking about that? If somebody's trying to think about readiness and considerations, what are you looking for? Is there something people should be working towards?
So we haven't had, number one, no, it hasn't required ICD codes, although I have to say, week before last, I was working with one of my communities to get ICD codes. So like we do all of these things. It doesn't have to have clinical care guidelines, although just as a general thing, I think those are a great thing. And we're trying to figure out how to scale implementation of those when they're available. So it's not really about those types of things. It's really about, if you were, as a clinician, performing best practices with what's available, what would those outcomes be? And sometimes for these ultra rare conditions, there's not a huge data stack in terms of being able to do that. So we go by our best judgment, and some of it's just because we know some of the spaces and we phone friends and, find these things out.
Okay.
But I do think, and I'll just throw this out there to be a little bit provocative, and because I know you've got creative people listening in, is I am thinking about, newborn screening. Do we just have the one bite at the apple in terms of in the newborn period? And if you're doing this when a baby is about a week old, and remember, if you can, what it was like when you were, with your newborn at home and doing that, with that sort of state of mind that you're in and with the relationship you have with your baby at that time is a vulnerable time. I'm just saying that out loud. And so I have to think about what the impact is on families of getting the information. And if you're not perfect, if this is still a screening test and you're not perfect in doing that, both with false positives and with some very, very heavy information, and how you will adjust to that. And will you be empowered, Or now will you be skeptical? Will you be petrified? Like, how are you going to react to that as a parent? And I know we've all been thinking about this. And if that, when your baby's 7 days, and I'm just be provocative because I don't know if I can do something like this, but is there a better time, and is there a better time for different conditions in terms of for doing that? So I'm just putting that out there to be provocative because I really want to do the best things for our babies and our families in doing this, and I don't know the answer. And so I'd like to get to what is the right answer, and then let's figure out, is there a way we can do it? Maybe there is, maybe there isn't, but I would love to have community feedback on that point, especially.
Yeah, I think that's a great question. I know for Duchenne, and then we'll, Catherine, tee you up for some thoughts around this. That was something that was considered for some of the neuromuscular diseases, at least, and there was funding provided by CDC to PPMD many years ago. Catherine, you may remember the year better than me, 2009, maybe. Come
8
off
or
mute.
9.
Okay, I missed that. Yeah, 2008 or 2009, to think about if we could line it up with sort of that 6-month time, that 6 month to 18 month, and think about if through like pediatrician, sort of the typical Bright Start, early identification time periods, there could be time when you could look for diagnostic delays and doing CKs, and were there other differential diagnoses that could also be picked up in that time period? And there was an entire algorithm built to do that, and training that was sent out through physician assistant programs and nurse practitioning programs. And we worked with NSGC and ACMG and all these other organizations and pushed out all this training. And still then we had data through the CDC surveillance program and the muscular dystrophies, even after doing all of that work and that coordinated effort with AAP and others, 5 years later, the mean age of diagnosis had not moved. And so our takeaway had been that the only public health program to really circumvent the diagnostic odyssey was newborn screening. That's not to say there might not be a better time period, to your point, but if we want to really make sure that we're not losing people to follow up and not catching everybody, then newborn screening was the way to go. But I do think that's where sort of early check came in, and they were also working on that. Catherine, I'm interested in your thoughts about treatability, because I know that's something, what does a meaningful intervention or treatment equate to? And that's something that's come up a lot in a lot of the communities that have gone through the RUSP evidence review. That comes up a lot. Can you speak to that as somebody who's been going through that?
100%. And we have experienced, to Wendy's point, the spectrum of perspectives on what treatability looks like. I think on one end of the perspective is folks who prefer quantitative over qualitative data, and they are looking for statistical significance in terms of changing primary clinical outcomes for folks. I think even on that side of the spectrum, it's not looking for a cure. It's looking for a clear clinical difference in outcomes for these kids. And then on the other end of the spectrum, we have seen more increase in value of qualitative data from the experiences of parents. And we have seen what was articulated to us was that they aren't necessarily looking for a statistically significant difference, but they're looking for a notable trend in changes in outcomes. And those outcomes are going to be different depending on the condition. I think one thing that I would emphasize that was said in your prior discussions is that partnering, becoming friends with, having meetings with the folks who are thinking through this and advising and making the decisions, and however the RUSP conclusions are drawn in the next coming years, being knowledgeable about that process and talking to the people who are part of that process to know more about what they're looking for is really, really valuable, and making sure that you are being sensitive to that ask.
Great. Thanks, Catherine. I think what I'd really love to shift to next, and Dr. Albeck, I'd love to start with you, is one of the areas that I think we're all very concerned about and very sensitive to is, what is the experience of the family that's going through the screening and and understanding that it's just such a pressurized time to begin with, the time when you're having a newborn. And so I'm really intrigued by what you've built and what you've set up, and also intrigued that much of it's being done through chatbots, because so much of the challenge right now is, the fact that we're trying to do this in the structure of a public health program. And we create pilots through processes of informed consent. So we have the benefit of having people there to consent families, but then when we move to public health, so many times families don't remember signing the form or don't remember the heel stick. So can you talk just a little bit about what you're learning through this? And my other question is, are you then also collecting any data around what families' experiences are in that process?
Yeah, so we have done studios where we talk to families that it's like a focus group where the family either had a false positive, or they're a carrier, or they actually the child has the disease. And the feelings that came up from the families are very different depending on what their result was. Like if you look at families where the baby hasn't been born yet and they're just learning about newborn screening, they care a lot about like the data stewardship, and is the government going to steal my baby's DNA, things like that. Whereas if you talk to families that have received like a newborn screening result that has been life-changing, they're the biggest advocates for newborn screening that you'll ever meet. So it's really, really different. I think one of the things that has stood out to me is parents talked a lot about the actual delivery of the positive newborn screening result, and that can be pretty horrific. Like some families had horrible experiences actually. The phone call where they were told something wasn't quite right. And that was motivating actually to get involved with newborn screening programs and try and fix that. I think the other thing that came about with meeting parents is there's like an urban-rural divide. And so meeting parents in really rural states like Wyoming, the services aren't really there. The knowledge isn't there. And being able to like provide something like a stopgap, like tool that will meet their information needs, even though they live in a farming community and they're like hours away from the a big medical center. I think it's really important because they feel isolated. They call people and nobody knows. No one's heard of the disease. Nobody knows what, you know, how to answer their questions. So I think that's like a gap that we have right now.
Yeah, I mean, curious, when you did your focus groups, what was the experience of those who'd had false positives?
The false positive people, uh, they're harder. That was a harder group to find, so we had a smaller group of
Yeah,
parents.
imagine.
I would say that those people were the most mellow in the parents that we interviewed. Like they realized the value of the system, and probably quite grateful that it wasn't actually, they didn't actually have
Yep.
the disorder at the end of the
Yep.
day. But they were a lot more positive than parents who hadn't experienced it yet.
Yeah. Yep. It's really helpful to understand. Dr. Chung, you were saying that you've made a strategic decision to have a more sensitive test. And so there's, it has implications for the false positive rate. Are you doing any type of systematic or methodological assessment of the experiences of families that are going through Guardian?
We are. So we're doing quantitative and qualitative. So we do large numbers for follow-up surveys, as I was saying, a month after we give results, and then on an annual basis, and then semi-structured interviews. At the end of the survey, we ask who will be willing to speak with us through that. So then the people that are volunteering, we speak through them one-on-one. We don't do a focus group for privacy concerns. And with this, it's interesting that, like all of us, there's also a time element to this. So, how people respond at one moment in time, things change for them over the course. And I think part of that, honestly, is that once you get a diagnosis, you also, I think, pretty quickly hook into the rare disease community once the diagnosis has been confirmed. And in a good way, I think we teach each other about all of this. Many times the community knows more than their doctors do, to be honest, and is helpful in terms of guiding along that process. I think sometimes what happens, which is tricky, is that sometimes you hear some of the really bad outcomes because people have been diagnosed late, and they've been, I think, some of the worst outcomes, unfortunately. I think that scares people, at least initially. And I'm saying this in part about how to welcome new people into the group, and especially when they come in through newborn screening. I think you actually have to be mindful as a rare disease community supporting them and their perspective. Because they see some of the worst outcomes and they get scared and nervous about those. In some cases, and it's interesting who feels differently, some people feel quite grateful that they've had this gift really to be able to have this information early and prevent, what are some of those really bad outcomes. But like I said, different people sort of take it in different ways, and over the course of time, I think they sort of come to terms with how certain they are about the diagnosis, and as they see data or their own observations of their child, once they really get their head wrapped around it and come to terms that it really is something, but yet feel empowered to do something about it, things start to, and if things are going relatively well or very well, then I think those are the families that have really good experiences and end up being quite grateful if I try and map out what that journey looks like.
Mhm.
But it's complicated, and I'll just say it out loud because it is one of the ones that I've been trying to think of. Again, I look to the community for input on this. I did make a strategic decision, and I'll just say this is quite controversial, but I'm putting out the controversy in terms of including MECP2 or Rett syndrome. And just for those who don't know this condition, it does have an FDA-approved medication, something called trofinetide. It does have early intervention, which I think actually helps the outcomes. But you're still left with residual symptoms within this. And the tough, very unique thing about this condition is the girls with this condition developmentally start out normal, and then there's a period of decline. But I did this because there are and were at the time we started this clinical trials that were open, not for newborn babies, but clinical trials that were open for Rett syndrome. And my feeling was like SMA, ultimately, even pre-symptomatic treatment was going to help those girls achieve the most and the best outcomes. So I was trying to, for the community, be forward thinking, because if we had individuals who, again, were consented to do this and came into the study, we would be able to have early biomarkers to know that, in fact, they were going to be symptomatic and identify and have an on-ramp to be able to know who to treat and how early they likely, who was going to be symptomatic, so we'd know they needed treatment. But it's been, I will say it out loud, if you can think about that journey, that's a tough journey for a parent. And so that's what I mean by even you have to condition by condition, be sensitive to what the issues are, the natural history, what that parent journey is like. And I wish I had the flexibility to completely tailor this for every single condition, but it's scaling this for ultimately what'll be 3.6 million babies in the United States. That becomes quite complicated. So we also have to think about what we can afford to do, what we can logistically do. But like I said, I would love to have some creative solutions to thinking about what's the best way of doing this, and then let's do the best we can in working towards that.
Yeah, for sure. So let's talk a little bit about, let's shift a little bit into the details of the data collection if we can. I know one of the things that comes up a lot when we talk about evidence collection or what would really enhance the evidence review for newborn screening would be the existence of sibling data in many of our communities and conditions. Whichever one of you wants to talk a little bit about the complexity of sibling data collection and maybe any efforts that you've been a part of to include sibling data or data cohorts in any of your efforts. And I see Catherine, you sort of moving towards the mute button.
See my arm shifting toward
Yeah,
my
I saw you go there.
mouse. Yes, so that was a big ask in the Duchenne world, that if we have a boy who's diagnosed at the average age of 5, and then his younger brother might be diagnosed significantly younger than that, or maybe even close to birth, we know that steroids can be used at any age. There are other treatments, genetically based or other sort of second generation type steroids that are available at age 2. Can we find those brothers and really articulate what the differences are for them 10, 15 years down the line? And really any data collection we found that required a great deal of detail about individuals, it was very challenging. We went to clinicians to ask if they had siblings that came to mind. We've gone to our registry and reached out to folks who are participating there to ask if there are siblings or if their data looks like there might be a sibling pair in that registry. If we could learn more about their experience. And finding those siblings can be a challenge. And then having the data that is asked for is a challenge. What the ACHDNC would like to see is siblings who have that difference in diagnosis, which was not always the case for our Duchenne families. We'd have a boy diagnosed at 5, and then his brother still took years to get diagnosed. He got diagnosed at 4 or 5 himself. So we didn't have those differences. The difference in treatment wasn't always there for our Duchenne families. We might have had a brother who was diagnosed at 5 and one diagnosed at 2, but they weren't aware of, or their clinicians didn't have access to those early treatments. They didn't get treated until about the same age. And then the longitudinal data. Have they gotten to age 10 or 15? Have they gotten into their 20s? Can we actually look at what their clinical outcomes were at the same time? Can we say what they're, for example, with Duchenne, one of the scores for Duchenne sort of muscle use is called the North Star. Can they do the North Star for both of them at age 10 and see what the difference is? That was really challenging. And I'd actually pulled up some of the numbers from our registry before to have on hand for this discussion, because when we looked at our data, we had over 6,000 individuals in the registry at that time. We were able to identify about 60 who looked like brothers. And then to get the data that we need to know when they started steroids, how long they were walking, any other clinical outcome data that we could get from them. And then we also needed that actual difference in treatment time. And from those 60 or so pairs of boys, we only had 4 for whom the parents had reported both the steroid initiation year and the ambulation data. And then of those 4, we had 0 that had actually started treatment before age 5. No individual brother had started treatment that young. So from that huge data set, it became very, very narrow. And that's what pushed us to send out emails. Can we find anyone? And we really only found we found some case reports that we were able to pull for this data report. But again, that concurrent data where it was data collected at the same age was still really, really rare to have. So one thing that is a big initiative for our registry right now is really empowering the community and creating passion in the community for developing that longitudinal data, how powerful it can be to have data throughout the lifespan that we can turn to when these asks are made. Because we know from clinicians, from parents, that there are these differences, but if it's not accessible in that data to be reported out, to be available for these conversations, that the power of that data can't be used.
Yeah, for sure. Well, you're on the topic of the registry. PPMD has the advantage of having a pretty expansive, pretty sophisticated registry. And I believe I recall when there were novel data elements added, anticipating the newborn screening pilot. Can you talk a little bit about what that effort looked like, how you sort of went through the registry and determined whether or not new data elements would need to be added, and in the anticipation of having individuals enter the registry at a younger age?
Yes, and I wish I could speak to this in a little bit more detail than I can, honestly, Annie. It could be that you can supplement this. But I know that anytime new data is being considered, we have a wonderful steering committee that includes family members and researchers and clinicians to really dig down and get the perspective from all of these different stakeholders into what is important at these different time periods, what is important to answer the questions that we feel like are coming down the line. And then the registry is pushed through surveys that folks can answer either on their phone or soon to be online as well. And we go through iterations of those surveys to determine how folks are interpreting them and if it's collecting the data that we really need. I believe that around that time, one of the new data asks, or rather one of the new sets of questions that was made, included questions about what the earliest symptom was for folks and how people were diagnosed, in order to separate out those folks who were diagnosed early because of family history, or folks who were diagnosed early from newborn screening. Is there anything else that comes to your mind, Annie, as we're talking about that?
Well, I would say there was a pretty extensive relationship with the Newborn Screening Translational Research Network at that time. And there was a clinical working group that was established in conjunction with NBS-TRN that looked through the data elements and made some recommendations at that time. So there was an enhancement to the module, the data collection module, both for data collection in the registry, but also for longitudinal data collection as well. So that the intention was that there would be some syncing of the longitudinal data collection once Duchenne was added to the RUSP as well.
Absolutely. And I'll add to that too, thinking into the future, one of the other programs that PPMD has is Decode Duchenne, the sponsored genetic testing program. And another change that we made to that program in anticipation of newborn screening is adding to the test requisition for that, just a little checkbox to say, are you ordering this as part of a newborn screening follow-up process, so that we can capture how many folks are being diagnosed that way, how that program is being used, so that we can turn back to that data to understand it in the future.
Dr. Chung, maybe I'll turn to you to talk a little bit about data collection also, because you now have so many more than 450 conditions that you're screening for in the platform. Can you talk a little bit about what that data collection looks like, and whether there's an ability for the patient organizations or organizations affiliated to be learning from outcomes that you're tracking in a longitudinal way? Like, what are those efforts? Because I know you work in collaboration with a lot of different patient communities. So can you talk a little bit about that?
So it's not all that sophisticated, to be totally honest, in these early days, that even though, we screen 20,000 for most conditions, we've got one in terms of if we've been lucky enough to identify a baby, it's just one baby. There are a few conditions, G6PD deficiency, where we have large numbers, but the outcomes in that are relatively sparse. So our process for doing this is a generic review, medical history review, and then impact on families and quality of life. And those go out to everyone. And then we do a medical, with permission from the families, we review the medical records to be able to then, we hand curate this. And at this point, based on the volume, we can do that, and we can pull out, we know enough about the conditions to know what we need to pull out in terms of the relevant elements. What I can envision is that I will say that when you get to, I know everyone here knows this, but when you get to population-based screening, you realize you don't know what you thought you knew. So what I mean by that is that the spectrum in terms of the phenotype, I think, is wider. For some conditions, you end up with people who are less symptomatic than we're used to seeing through diagnostic testing. And I have had the experience that we also miss people who die from these conditions, that the value of newborn screening is that we get people that may be even more severe, but at a stage, hopefully, where they're treatable. So the reason why I say that is that you have to keep your eyes wide open and continue learning. And again, I get to this iterate in terms of you may need to add measures or add ways of collecting data at both ends of the spectrum beyond what you thought you knew. And I do think that we're actually going to have to rewrite the clinical care guidelines based on newborn ascertainment from newborn screening to keep these things in mind and keep eyes wide open. So I'll just give you one example. For long QT syndrome, which is one of the conditions where we do have a fairly, the prevalence looks like it's going to be 1 in 1,000 births. So for us doing 20,000, we're getting to fair numbers. The Heart Rhythm Society has very good guidelines in terms of how you monitor, survey, and follow these individuals, and they're very good evidence-based guidelines. But an EKG on a 14-day-old is different than an EKG and probably how accurate it is. And so you probably, if you ascertain with newborn screening, you probably need to do serial screens. Thankfully, 14-day-old babies aren't having, syncopal episodes largely and passing out. So you don't have a lot of sort of symptoms. They're not telling you they're feeling lightheaded. So you have to use different data points in a little infant. And then over time, you get more data and you may make adjustments. And luckily, you've got direct physiological readouts to know how you should make those adjustments. But the point that I'm making is that I do think as a rare disease community, we ought to think about infrastructure that'll help all the boats float, that tide that'll be effective and cost effective specifically, because the faster we can do this, the better it is for everyone. And there are enough common elements within these things that I do think there's an economy of scale. There ends up being this sort of a little bit of a clash of where does the money come in? Maybe that was what you were getting into earlier, but where does the money come in? Who owns it? Who controls it? Who makes sure no one's left behind? Is the person competent or the group organization competent that's doing it? So there are some tensions that always arise when it comes to these things. But otherwise, it's just enormously expensive for each rare disease organization to do this totally on their own. So at the very least, I'd say maybe clusters of conditions, the things that have similar features, or, common things, common platforms, common infrastructure that'll help us to do this more cost effectively.
Agreed. Here, here. Karen, I'm wondering from you, I'm really intrigued by that. I would like to learn more about the chatbot. I'm really intrigued by that. And I'm wondering, so today we have a lot of groups who are really working to improve, build this ecosystem. And I'm interested in sort of that algorithm that you build into the chatbot to support families and to support their decision making or answer questions that they have. And I'm wondering if, based on what you're learning, you would even have recommendations or, even common threads that are coming up in those conversations with the chatbot that would be important for us to know.
Yeah, so the chatbots that we've built for newborn screening in particular, they're scripted. When we don't want to have like a large language model say something that's not true. So the best way to describe it is like a choose your own adventure. Like, you remember those books from when we were kids, right? So we provide the parents with first off an introduction. And so for the trait chatbot, we tell them immediately this is not disease, and we explain what trait is. And then we lead them to a menu of subject areas where they can go find out more information. So it's not really an algorithm. It's more with the back and forth with the pediatricians and the genetic counselors. It's like these are the questions that come up. And what we found with our surveys and our interviews is that the parents really like that structure. 'Cause these are, it's like a terminology that most people have never been introduced to before. And so providing that choose your own adventure, you can dive into this topic today and learn about, the inheritance or something like that, right? It provides like the ability for the parents to learn about something new in their own time. They can come back the next day and check out a different question if they want, but they really like the structure of that.
And
The-
how have you decided which conditions that you've built the chatbot for? Is this something you're thinking about scaling up? This is
it's
not intended to put
scalable.
you on the hook. Just we're
No,
super
no, no. So
intrigued that this could be scaled.
in Utah, in talking with the follow-up team, so they return all of the trait results for the hemoglobinopathies. And that's like it's like 80% of the results that they actually return in the state are trait results. And so that's where we started to build the chatbot. Um, with the idea that that would help with like the provider burden. So if we could answer some questions just automatically, like you sit on your phone and answer those questions, it would free up the follow-up team to actually be doing more urgent interventions. So that's how we decided to focus on the hemoglobinopathies to begin with. And then with the changes with our legislature this season, it was like this is a really obvious thing we need to pivot to actually help parents understand what they're consenting to when it's so that was a little bit reactionary, but I think it's a necessary thing in our state right now. And I think with consent, the way I think that's gonna move is I think most newborn screening, like the metabolic tests, it's an opt-out model right now across most of the states. I think as we move towards more newborn genome sequencing, you're gonna need some kind of hybrid model for consent. So some of it's probably gonna still be opt-out and some things are gonna be opt-in. I think a chatbot's really like useful for explaining those differences and providing that like as you need it way to access the information.
Yeah, that's really interesting concept when you think about the ability to relieve provider burden and get real-time information to people, at least to bridge that time period before there's a provider available, Monday morning if results are being delivered on a Friday afternoon, which often ends up happening. So that's really interesting. Is there a plan to be publishing what you're doing, publishing results from what you're doing?
Yeah, there's a plan. Hopefully this week we'll get the medRxiv paper out with the results from the hemoglobinopathy chatbot, and with the idea that that will turn into a proper published paper at some time. Like, but we do have a grant going in October, so we need to have something out there, right? And then we hope to do some grant writing around this.
So first of all, you're saying that this was a late breaking session, so we appreciate you being here for that. But that was a nice segue into funding. So let's circle back to funding. I'd be very interested in you guys sharing where funding has come from. Has that been a struggle or a source of angst for everyone? And thoughts about ideally where would funding come from? So we'd love to talk a little bit about that.
Do you want me to go first?
In whatever order.
Go ahead.
Okay.
So I think funding in newborn screening, if you're not part of a program, can be challenging. For me, I have had some success with the APHL. So they provide fellowships. And so I've been able to fund people who work in my lab, which is huge. Like the people doing the actual programming are funded through like a health informatics fellowship, and I will always be grateful to the APHL for that. And they have partnered. We run a master's program, and so our master's students, if they're interested in public health, they can obtain APHL funding in the second year and build their capstone around public health research, which I think is huge. Other than that, I've had foundation funding, and I'm working on NIH funding. I'll put it that way. I don't want to get angry, so.
Okay. You also have a lot of people watching today who are advocating for steady and robust research funding, so.
Yeah, you just have to get to the right study section, I think. I think there's some crusty old people that don't think that this is a problem at all.
You have a lot of champions here today. Dr. Chung.
Yeah, I'll just say, Annie, as always, you put your point on or finger on one of the hearts of the matter. These are expensive to be able to do at the kind of scale we're talking about, and I think need to be done. I'll also say that if you look historically at other pilot studies that have been done condition by condition, it's the ones that have either been more frequent or that have had the resources, either through patient partnerships to be able to fund these, and that's great when they can, but not every rare disease has just the resources to do that. And I don't think fundamentally that's a fair process. I'm not saying anything against the incredible advocacy groups that have made it happen, but I do think ultimately that's one of the problems with scale. We have, just for full transparency, and this is on our Guardian website as well, we have gotten in-kind resources from Illumina as well as GeneDx that help with the actual genetic sequencing and then the interpretation of the data. And then for the other, which is enormous, but the other staff that we have to have for recruitment, education, return of results, all the follow-up, all of those things have really been funded by philanthropy, which are not direct specific patient organizations for individual conditions. To be totally honest, they've been people who believe in me and us as a rare disease community and have the vision in terms of being able to move this forward. And that's a very special thing. And we're incredibly grateful to visionaries like that, but they don't have infinitely deep pockets in terms of doing this. And I will say, and I'll vent for 2 seconds, it is interesting that some of the folks that I think directly would benefit from this, and I'm not necessarily saying just patients, but from a business point of view, that I think if you were logical and really thinking just purely about what your business is and the opportunities for doing this and have a real stake in this, basically, many of them, it feels to me like want to go for a free ride. And I get in terms of like, why should you pay if you can go for free? But I do think ultimately we're all holding the entire opportunity back in terms of as we think about treatments for rare diseases. But I'll be very specific because I think if you can diagnose these conditions early enough, there are new treatment opportunities in the future that biotech pharma has given up on for rare diseases because they figured it was too late. We can't get in, we've got to get in very, very early. And although it's not, it's still after birth, I do think it opens up tremendously new treatment opportunities. And I would love to see a willing coalition of many different partners come together to make this happen. Because I literally, every day that we don't make this happen is another day we lose an opportunity for a child to have a healthy life. And with doing this, I know we're de-risking treatments for rare diseases across the board. And it's in this day and age, I have so much hope and impatience, I will say, in terms of making this happen, that I don't want to be reckless. I'll be very clear. I think we need to do it in a measured way to make sure we're doing it well. But once we know we're doing something right, we need to have enough data to make this, from a policy point of view, to make some important policy decisions. Because this, again, I think you and I agree, this should be in the public health setting to make sure we don't leave anyone behind. Those dollars come from people that need to decide, their scarce resources, where should those dollars go? And the better the evidence we have in terms of what we're doing to outcomes, including the health outcomes, the educational outcomes, the family outcomes, and dollars and cents, the more persuasive an argument we can make. And
Yes.
it's a numbers game.
Yeah, for sure. Catherine, funding.
So one of the early wins for Parent Project Muscular Dystrophy was the passing of the MD Care Act in 2001. So I want to call back again to previous conversation. Kelly Fitzgerald was talking about finding your legislative champions, just meeting people, sharing your stories, finding these partners who can help envision these opportunities for funding. So through the MD Care Act, there are federal funds directed toward muscular dystrophy research. And every year, someone is awarded CDMRP awards to do Duchenne muscular dystrophy research, which isn't always newborn screening, but the most recent awardee is for the baby Duchenne out of Rochester, Dr. Bohun Lee and Dr. Emma Sheffaloni working on data collection, developing natural history, developing longitudinal data post newborn screening for babies diagnosed with Duchenne. And that is so important and special for newborn screening conditions to have a cross-state, cross-center network to collect this data and understand these babies and improve care going forward. That is such a powerful resource that, many thanks to Pat Furlong, our founder, and the legislative champions who helped make that happen. But certainly other grants, absolutely industry partners that can provide funds where many can't. We're very important for funding the many of the pilots for Duchenne. And then private donations are fairly robust in our community. So working on devising fundraising events that can be powerful for your organization, and finding your partners for that can be really helpful too. We've also been very grateful in the times that we can lean on just research champions, again, people who really believe in this mission. And there have been times where there have been folks who have done sort of pro bono or much cheaper work for us because they are impassioned by this mission, and they work with their patient communities and see the damage from these late diagnoses. And we're so grateful for those folks too.
Thanks, Catherine. Given the time, we did not get to the thread around, there were some questions in the chat about the need for more training for healthcare providers, which we could not agree with more. Just because sometimes the report out of results get diminished by the first primary provider you may speak with until there's a confirmation. But I trust that probably the next panel may pick that up, given who some of the people in the panel are. I do want to say, and just some closing comments. First, thank you so much to this panel. I think this was an incredibly rich discussion. Just those who know me know part of my soapbox is, though, that I think this discussion also underscored that so many of the rocks fall into the backpacks of patient advocacy organizations to do very savvy, very expensive work to move this field forward. And I think it was Dr. Chung who said that we really can't leave all of that into the hands of patient groups to do all this work. What Catherine didn't just say, she mentioned a lot of people who contributed to the funding, but I think PPMD, over the time they've been driving the Duchenne nomination forward, has spent more than $6 million themselves on this, or pulling the community together. So it costs a lot of money, and most organizations don't have that to spend, and PPMD didn't at the beginning either. And it shouldn't cost a patient organization that much money to do this. And we will and are leaving conditions that are treatable behind when that's the infrastructure we have developed. So we need something different. So what I'm hoping, though, today that we're providing to those who are here with us is nuggets and places to start. That if you're listening today, you're getting sort of what are the first steps? What's the low-hanging fruit? Where do you begin? And then what's that roadmap, so that you don't have to reinvent the wheel, and that there are so many partners who've gone before. And then the last thing I'll just say is that all of the people who've been presenting here today have been extremely generous in sort of creating that roadmap and carving that path, but also are super generous with their time, and are always very happy to share their knowledge and share information, and pass that on to those who are coming next. So if you're a new group that is working on a condition, please reach out. And we're happy to put you in touch with folks that you're hearing from today. So I just want to thank this panel for your extraordinary work. There are a lot of people, I don't know, Dr. Albeck, if you're seeing, who are fascinated by the chatbot, and we can't wait to see your paper and see opportunities to scale that. Of course, Dr. Chung, thank you for your leadership and all the work you do for our communities. And Catherine, all the work you've done, and we're anxiously hoping to see a nomination to the RUSP for the Duchenne community. So thank you all for being here with us today. And Dylan, I'll turn it back to you.
Thanks so much, everyone, and thank you so much for a fantastic panel. And we are excited to pass it to our final session of the day. Let me bring my screen up one more time. And with that, I encourage the panelists in the final queue, I see, start trickling in, but we're really excited for our last session of the day. Looking forward to newborn screening. So we've had a lot of information discussed today around states and the importance of research, but we want to start the conversation around what's next, how do we move forward, and making sure that we include some action items. And so with that, we have really excited for our panel today, and Natasha Bonhomme will help to moderate and lead that panel. And so with that, I will pass it over to her to introduce our fantastic panelists. Natasha?
Great. Thank you so much, Dylan. And thank you everyone who is, on the line, has been with us for, what are we moving into the third, fourth hour? This has already been such a great boot camp. I was just thinking, this has been 7 years of this partnership between Expecting Health, which I'm the founder of, and the Every Life Foundation. And so really looking forward to be able to speak about the future of newborn screening in this session. Just to give a bit of an overview of how this session is going to go, I will talk a little bit about the goals. I will give a little bit of background around the National Academies of Science, Engineering, and Medicine report, which was already referenced earlier today. And then we'll go into more of a discussion with the panel. But to start, we really wanted to be able to use this time with our panelists and speak about, in particular, the past 6 months in newborn screening, and really all the different things that have been going on and what that means for the future of newborn screening, both from a range of different perspectives, whether that's clinical, federal, patient advocacy, and to really use this time to think about, where we go and what are the tools and supports that are going to be needed. We will, as part of that discussion, we will talk about, the status of the advisory committee. We'll talk about what evidence review looks like moving forward. We will talk about the role of genomics in newborn screening, and also, what are some potential immediate actions we can take moving forward. So I'm going to introduce our speakers, and then I'll give a little bit of background on that National Academies report. But first, we have Dr. Jeff Brosco, who is a pediatrician and historian who teaches and practices general pediatrics and developmental behavioral pediatrics. He has been involved in newborn screening policy at the state level for the state of Florida, as well as the national level for more than 2 decades. Most recently, Dr. Brosco was the director of the Division of Services for Children with Special Health Needs at HRSA, the Health Resources and Services Administration. As the director, Dr. Brosco, Jeff, really spent a good portion of his time leading the team that oversaw the Advisory Committee on Heritable Disorders and the RUSP process. That team also worked to fund states in implementing new conditions, improving short-term follow-up, and planning for long-term follow-up. We also have Terry Klein, who is president and CEO of the National MPS Society. She has spent 2 decades advocating for individuals with rare diseases and has been with the society for 17 years, so has really seen a lot of change in that time. Her expertise is in organizational development and multi-tier funding development and patient advocacy. So I think even some of the questions from the last session will probably spill into this one, and Terry can really speak to that. Under her direction, she has implemented a number of different new programs, really looking at improving access to healthcare for rare diseases. And in part of her work, she has had 2 successful newborn screening nominations for MPS 1 and MPS 2 in collaboration with HRSA, and really sees that as some of the most significant work that she's done. We also have Megan Curlis, who is a policy analyst for the Washington State Newborn Screening Program, with a focus on really future directions and where state programs are going and how that expansion is going to take place. She's facilitated a number of different condition reviews in Washington, everything from the initial research to implementation and having those screening programs go live. She works really closely with the State Board of Health and provides subject matter expertise to the State Board of Health. And she serves also as a liaison for researchers and advocates within the state of Washington. And before that, she spent over 5 years working on the disorder follow-up team. So really understanding what does it look like when you're reporting out abnormals and abnormal screening results to healthcare providers and families, and really helping with that link to specialty care. And last but not least, we have Dr. Cynthia Powell, who is now an adjunct professor in the Department of Pediatrics at the University of North Carolina School of Medicine, and she's recently retired. And I just have to say, I don't know if every sector is like this, but in newborn screening, people retire and then they're still working. Sometimes it seems like they're working even more. They're showing up even more on more panels. So that's a question maybe for a different time, but just wanted to note that. Cindy Powell is a board certified clinical geneticist, pediatrician, and genetic counselor. She is a former chair of the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children, and a member of the board of directors at the American College of Medical Genetics and Genomics, and is currently chairing ACMG's RUSP Continuation Task Force. I know that is a lot of background, but I think it's important to see the different hats people on this panel have worn and are continuing to wear, and really thinking about all the different perspectives we have here as we wrestle with the question of what does newborn screening look like in the future. So I'm just going to take a few minutes to speak a little bit more in detail about the National Academy's report on newborn screening that, as I said, has been mentioned a couple of times before during today's panels. So the U.S. Department of Health and Human Services had asked the National Academies to convene a committee that would examine the current landscape of newborn screening in the U.S. and make some recommendations about what are the options and opportunities to strengthen public health newborn screening and to help set a vision for the future of screening. The committee had 14 members with a range of different expertise. Of course, there's expertise in newborn screening, lived experience, bioethics, but also in looking at emerging technologies, federal public health, and other health systems, as well as there were people who are part of the committee who had a focus area of health economics and clinical care. So really a really nice, rich mixture of different perspectives were brought together. And they worked together for a bit over the course of a year, doing a range of different activities, including reviewing literature. They held a number of public workshops and webinars. Both Every Life Foundation and us at Expecting Health participated in those workshops, sharing the information we have. And I believe there were over 600 people who, throughout all of the different engagements, were reached out to and were part of different discussions about the report, which I think just goes to show how many different viewpoints had to be pulled together and collected to build out this report. The focus of the group really was to look at newborn screening as that public health service and what's needed for the future. There were definitely a number of different challenges and opportunities that were laid out, including some of the things we've talked about already today in the boot camp, such as scaling condition by condition and the time that takes, and the burden that really puts particularly on patient advocacy organizations. thinking about how do we strengthen newborn screening programs when the landscape is changing and shifting and every state has slightly different issues that are emerging. The ever-present and expanding issues around privacy and consent, as well as how do we improve newborn screening delivery when we're really thinking about data collection and really clarifying what are we screening for, what does it mean to have a screen positive, what's a false negative, and what does that look like as we're expanding in the space of newborn screening. And lastly, with all of that, what is the responsibility of a true public health newborn screening program? And what can public health actually address and not address? And what are other things that really should be looked at in parallel, but maybe not necessarily within a public health program? So that is a lot. There were 9 key points that came out of the report. I'll list them quickly here. Establish national leadership and priorities and incorporating input into those priorities. How do we optimize decision-making on conditions? Support program excellence and performance. Really amplifying and sharing newborn screening resources. That is something that's already come up. There are a lot of resources out there, but it doesn't always seem to get into the hands of the people who need them. Expanding newborn screening education and awareness. Really thinking about specifically for newborn screening blood spot, the data standards and really pushing that forward, expanding coordination and research, as well as promoting the responsible application of technology. So there definitely, as I said, was quite a bit there done with the report. And 1 month before the report was released is when we all found out that the Secretary's Advisory Committee was disbanded, right? So again, this past 6 months, there have been a lot of different changes in the newborn screening world and the worlds that are adjacent to it. And so really thinking about what that looks like. So with that background now out of the way, I really turn it to our panelists, and I'll start off with kind of our first question here is from your viewpoint and your lens and the work that you've been doing, how has the newborn screening landscape, or how does the newborn screening landscape look to you since the release of the report and the disbanding of the advisory committee? And let's start with Jeff on that.
Thank you, Natasha. And first, I want to make it clear that I'm speaking as Jeff Brosco, the individual citizen and the University of Miami person. My last day at HRSA was a couple months ago. Putting on my historian's hat, newborn screening, it seems to be this sort of solid thing. State newborn screening has been around forever. And true, it started in the 60s, but almost every decade it has faced pretty significant challenges. And one of the interesting questions for me is whether the challenges we've had over the last few months are truly new and really disruptive, or if they're sort of the latest stage in the development of state newborn screening. And just to give an example, back in the 60s when it started, newborn screening was a routine hospital-based clinical test. It wasn't a state thing at all. And to become a state law was kind of a big deal. And that was challenged at multiple points in future decades. And the role of genomic sequencing and potentially expanding by hundreds the number of conditions. There was a similar kind of thing again in the 90s when we moved toward the MS sort of tandem aspect kind of technology. So I think that's one of the things is to sort of put it in perspective and say, how different is this? How new is this? And what will really happen next? I think folks probably know that the advisory committee is 20 years old. And so what comes next is yet another chapter in newborn screening. So with that sort of background, I think that and I'm not going to talk for too long because I want to make sure the others get a chance to weigh in. I'm sure you'll come back to me. I think that there are real opportunities moving forward and that the one condition by one condition approach to evidence review, it's hard to imagine that will work going forward. And I think it's great that the NIH is working, hopefully soon they'll be announcing what the newborn screening by whole genome sequencing project who's going to run it and kind of look at how do we help states incorporate genome sequencing into newborn screening, see if it's feasible, how it might work. So I think there's some interesting things on the horizon.
Great. Thank you so much, Jeff. Terry, from your perspective in the patient advocacy world, kind of how has that landscape changed or is looking like right now?
Definitely wear the landscape of wear the hat of the patient advocacy group, because we have to stay positive. We always have to move. We really do, in places of hope. But it was a little scary, and it was a little convoluted with information that first came down, that a program that's been so successful to save babies for decades is going into a stall moment while they find a new infrastructure, build a new architecture, build a new runway on how we get this done correctly. Going through the program for the past couple of decades and submitting our first nomination from 12, pulling from the other panelists earlier, there is a lot of resources, of funding, of time to successfully get a nomination approved. It wasn't for the faint of heart, but what we did experience was very positive understandings of how an ACHDNC worked and how real science was coming forward with key stakeholders to ensure that we did have quality data for a treatable disorder. And we realized that it did take time to get there. And so what we recognized was, how can we shrink the time? How can we use the integration of data sharing or future AIs or the whole genome sequencing? How can that help improve these timings? Because time is against our children. They don't have the time. That was noticeable. But when you have a situation here where we don't really have the program while we're trying to lift it and rebuild it, from the patient perspective area, it does feel a little scary. And so we need to get it right. And I'm so grateful that there are large groups like the ACMG and others, and hearing from Dr. Chung and Guardian and hearing what everyone's doing, and you're going to hear from Dr. Cynthia Pell too, that we have an opportunity to get this done better and right. But it didn't mean that it wasn't good. It was very good. It was very sound, so successful. But we have a way to make it better. And like Dr. Brosco just shared, we aren't going to be able to keep up with conditions one-to-one. So finding those ways to be able to group conditions and what they can look like across lysosomal diseases, which is where our passion is with NPS, is going to be very important to do. But I wanted to let you know that we're moving kind of forward with a little bit of anxiousness, wanting to be out there and advocate where we need to, and we can talk about that a little bit later on, and identify really what it is we can do as patient advocate groups in the interim while we're trying to reformat the program. I'm grateful for the report from the NASM. It was good. Thank you for sharing that with us. And it's good to see that they're trying to make a very strong footprint in progress going forward.
Great, thank you. And since you mentioned the report, I just want to say, I'm sure either in the chat or in the resources, there will be a link to the report. And also there was a webinar series held by Genetic Alliance and Expecting Health, a 3-part webinar series that goes in depth about the report. So for those of you who are interested in getting a couple of different perspectives on that, we'll be sharing that. But Megan, your viewpoint on this?
Coming to it from the perspective of an individual state-based program. And in particular for us, we had just become kind of quasi-RESP aligned, meaning that, anything added to the RESP, we were going to automatically put through our own review process. So I feel like we were really energized. We had a bunch of work ahead for us, especially with an eye to MLD and DMD, and the anticipated findings from that condition review. So from my perspective in our program, it kind of felt like we were speeding down the highway and had to slam on the brakes all of a sudden, and then kind of spent a lot of time just looking around, asking questions, seeing who knew what, and kind of what the new way forward was. So I've been trained to look for policy windows of opportunity, and that's what I see here. I try to look for silver linings. So I think potentially with the gap left by the ACHDNC combined with the findings from the NASM report, I think there's the potential to kind of make a larger impact than might have been able to be done previously. So I see a lot of opportunity and hope in that, particularly as far as more high volume condition reviews, since that's a lot of where a lot of my time and attention is. So I'm really keen to see kind of alternate solutions to that problem, since it doesn't seem like it's going to be slowing down or going away.
Great, thank you so much. And Cindy, your perspective as a researcher, as well as someone who's in leadership in a professional society organization and having been chair of this committee, what do you have to share on that front?
Yeah, I think it's important for everyone to remember the reason why the committee was dissolved. We were a discretionary advisory committee under authorization of the Newborn Screening Saves Lives Act. And that was not reauthorized when it came up for reauthorization several years ago. And my understanding is that HRSA and other government agencies did away with all of these discretionary advisory committees. So we weren't operating under an act, a government act, and that was where one of the problems came up. Now, the Newborn Screening Saves Lives Act has been brought up again in this Congress. My understanding is that it got out of committee recently. Whether or not it will come to a vote remains to be seen. There is a famous senator who has opposed the Newborn Screening Saves Lives Act. I won't mention his name, but if anyone is from Kentucky, you may want to contact your representatives in the Senate and tell them about the need for newborn screening, the importance of the Newborn Screening Saves Lives Act. Certainly that would help us a lot in getting a new government committee in place. As some may know, the American College of Medical Genetics that I'm part of working on, we've tried to see what we could do to bridge the gap since there's no federal committee. And we're trying to bring together stakeholders, not just from the college, but from other professional organizations and rare disease organizations to see, if there's something that we can do, because we know that there are a lot of conditions out there where there's either, a new approved treatment or clinical trials going on that, are important and may be, in a good position to be added to the RUSP. Now, the RUSP still exists, and hopefully that won't go away. But more and more, we're hearing from states that say they're being approached, like independently, can you add this condition, that condition? And I really fear that we're going to go back to the way things were in the late 1990s, where it was a patchwork of various conditions that were screened for in states. Some were still screening for 5 or 6 conditions. Others had added tandem mass spec and were screening for 30 conditions already. And, steps were taken. And that's really kind of how the advisory committee evolved, was to try to, have standards that all states should follow in terms of which conditions they were screening for. So I would hate to see a situation where, you're in, right over the border from a state that is screening, but your child is born in the other state and they get missed. Their condition is not detected at an early stage. So I'm hopeful. I remain an optimist that things will get better, but I think we need to understand, the politics behind what's going on. And then there's also the funding problem. Jeff may want to speak more about that, but people in previous sessions today brought up like the NBS TRN. Well, their funding was dropped from NIH. There's no more NBS TRN to try to bring together states and data, to look at newborn screening. We've never done a good job in this country tracking, what happens to children after they're diagnosed with the condition through newborn screening and treated. Is our treatment effective? Are they doing better than they would have otherwise if their condition hasn't been detected early? And, HRSA's lost funding in this current budget proposal. there's not going to be any more Propel grants and things that help states expand their screening and be able to, add some of the new conditions that have been brought up, like DMD and MLD. So anyway, I'm hopeful, but cautiously optimistic.
Natasha, can I quickly add a couple of things to what Cindy said? And by the way, please call me Jeff. I think Cindy and I both prefer the informality of that. As Cindy said, the patchwork approach where different states have different conditions, and part of the advisory committee and the RUS has been to make that much more uniform. It's exactly true. And that geographic disparity was always pretty awful. And the other part, of course, is the evidence reviews, right? The evidence reviews are extremely expensive and time consuming. And to be able to have it done nationally allows states to decide how much more they need to do or rely on that one national one. And if we go back to, not having that done nationally, then it puts all 59 programs sort of on the spot to have to do it themselves. And just to amplify one other thing that Cindy said that folks don't realize a lot, which is HRSA not only runs the advisory committee or used to, but also funds states. I think they're currently up to 39 states and jurisdictions to make sure that conditions that are added to the RUSP actually states have the wherewithal to bring them on board, and to make sure that short-term follow-up, that the timeliness and those kinds of key quality metrics are met, and also pushing for long-term follow-up to make sure that, yes, we've identified a child, we've helped a family connect to a clinician, but are they getting the care that they need further on down the line? And so the Newborn Screening Saves Lives Act that Cindy mentioned before, and the sort of commitment of the federal government to making sure that newborn screening works, not just the evidence reviews and the advisory committee, but also implementation. It's something to really pay attention to right now.
Great. Thank you so much for that addition, Jeff. And I think it's important to think about, what has been said in terms of really not wanting to go back to a point where there are such drastic disparities between states in terms of what is screened for, and no way and no path to really change that, right? We all know that different states have different numbers, and that is still part of the reality of newborn screening. But the fact that there was always this momentum to move to make sure those numbers don't stay that way year over year over year, and that there being a national look at, okay, we know it takes time and different states have different needs around adding conditions, but there was a clear though not a requirement, a recommendation, a goal to look towards to be able to have those numbers at least be a bit more aligned with each other. So thank you to all of you for really speaking to that. Since this has come up in terms of different approaches that could be implemented or worked towards when thinking about filling the gap, and I would say the multiple gaps that the advisory committee no longer being in place leaves, I think we tend to think about RUSP and the panels of conditions, but the advisory committee was also the place where at a national level, multiple times a year, the community came together to talk about a range of different issues, right? Whether that's privacy and consent, whether that was, other issues happening in maternal and child health that might have an effect on newborn screening. So, I open this up to whoever wants to take this question to really think about and envisioning what may come next. What are some of the key pieces that would be necessary? I was on that Secretary's Advisory Committee as an organizational rep for, I think, about 15 years, which is wild to me. But, really saw a lot. And a key piece that I saw from my viewpoint that made it successful were the opportunities to be collaborative and to have a range of different viewpoints. But, I open it up to our panelists to really think, in envisioning what comes next or the different things that may come next. What for you do you want to be able to see in, what takes the place to fill the gap of supporting a national vision around newborn screening? I'll let you all decide who goes first.
Well, I'll try to tackle that. I'm a strong believer in evidence and evidence-based reviews. One of the challenges the committee had was that there was only funding to pay for 2 evidence reviews a year. So I know there's, been a lot of displeasure and how slow things work, and those evidence reviews are tough. I think if we did a better job up front, getting evidence through pilot projects, I don't think we should leave it up to the advocacy organizations. There's a lot of promising conditions out there, and advocacy, their advocacy organization doesn't have funding, for something like that, for a pilot project. So I think we need, again, coming back to funding, if we had enough funding, we could do so much more in this arena. We could have pilot projects, we could gather evidence up front. It would be a lot easier to do those evidence reviews. So I do think that that's going to be really critical to help us move forward.
Anybody else want to take a crack at that?
Would say that I have part of my job is to kind of keep an eye on what's happening at the federal level with newborn screening. And so I definitely feel the void from those meetings and kind of the wealth of information that they provided. I've turned recently more and more to all these webinars that are being put on by advocacy groups to kind of fill in my gaps in information. And while I've so appreciated that, I regret that that burden might be being placed there. I'm looking forward to the newborn screening symposium early next month. I don't think that this happened in time for it to be an official agenda item, but I'm looking forward to using that opportunity to kind of hear others' thoughts and developments in this area too. That's kind of where I've turned recently.
In our perspectives on this topic, trying to think about what went really well and what was hard makes me think about conditions that are grouped together, kind of going back to part of the report, but there has to be a way that we can look to the future that allows us to be able to group expansion around lysosomal storage diseases and find ways within the evidence-based reviews where we can see commonalities that we can draw upon, even recognizing there may be variability. Because the one thing we do know is that because we have had success through the process of RUSP and HRSA and at state level advocacy, babies are being treated earlier. And we are now seeing this longitudinal outcome of data across these children that did have access earlier and were diagnosed at birth with these conditions. And we can't say that we really necessarily had that before. We had that in 2016 is when MPS 1 was brought on to the panel to begin screening. And it really is that we're just at 90% of the population in this country in the last year here for MPS 1. It's taken that long. There's so much here that we've done right, but you see in the window what we need to do to tighten up the timelines. And I really hope that we can get there in these advocacy pieces. And thank you, Cindy, for bringing up the reasons around why we don't have an ACHDNC. Because the funding component of what they talked about in the previous session is something that can seem magnanimous to a patient advocacy group. And we have to find a way to be able to nationally scale these nominations and this process so that they're achievable. I wanted to address something that you said, Natasha, along the lines of what I like to refer to as pioneer patient advocacy groups. We are serving missions to bring better health to the children that are diagnosed with these devastating disorders. If we don't see something getting done, we're going to jump in and do what we need to do to move it along. And that's exactly what I see has been happening in this area too, along with newborn screening. While we have the critical stakeholders that are reviewing these nominations, there unfortunately has had to be a reason for a patient advocacy group to come forward. Our mission state that we're here to cure and support those with these disorders in some capacity. And we have to be able to achieve that goal. And it devastates us when we can't get there and we see that there's a break in the road. And so I call it pioneering patient advocacy group work. And it is $4 to $6 million to bring a condition all the way across the finish line, because it doesn't take 2 years, it takes 10 and it takes 12. And so I'll just kind of leave it there. There's some of my perspectives.
Thank you so much, Terry. I really appreciate your comments, and again, really looking at the piece that sometimes we don't talk about, which is the funding and what does it really take, right? It's almost, sometimes you hear comedians say, oh, I was an overnight success. It only took a decade. And I think it's a very similar piece in terms of all of a sudden you see all the news articles and conditions maybe being added at the state level, or you see a nomination come through, but that doesn't highlight, all of the years and the expertise and the dollars that really went into that. This is a perfect segue to the next question that I had, was to really speak a little bit more about evidence review. What does that look like? The challenges in that. I think you've presented it very nicely, Terry, from the patient advocate perspective, but I'd love to hear from, our other panelists about that. And, what discussion should we be having now? For quite some time, we've heard about the challenges of the evidence review around the burden that it puts on patient advocates, or even just the issues around data and data collection in rare disease in general. But it'd be great to hear from Megan, Jeff, and Cindy, from your perspectives, your thoughts on that, and what you'd like to see in the future when it comes to evidence review, or that whole process of, you can't have a review without evidence collection, right? But that whole entire process of really understand, when we are looking at screening for a condition, what that means and what it takes to get to that point.
So I wonder if I can start, Natasha, because I think you and Terry stated it very clearly that these are such rare conditions and that it's just hard to gather the evidence base. And remember, the evidence has to be not just that there's a way to screen and a treatment that works, but that the treatment, when done pre-symptoms, like from the newborn period, is better than treatment when clinically ascertained. And that's a really huge bar to get over. But of course, it's a mandatory state public health program. So most ethicists would argue that it is appropriate to have a high evidence bar for a program that really, doesn't truly have consent. That said, I think it's also worth kind of laying out the timeline of these things. And as you've heard, it takes a long time to gather the evidence. The actual evidence review part is not as long as it seems. If MLD had gone through, it would have been less than a year. And in fact, there's never been a time when there was a waiting list. That is, that HRSA had more conditions than it could review in a single year. It's just that it takes so long to get the evidence together. That being said, I think there are good ways to move forward, and this is a great opportunity. And as you laid out in your discussion of the NASEM report, having a committee, whatever the next committee is, and whether it's inside government or linked somehow. And that link is important, by the way, if we want the insurance payments and so on to continue. That it needs to have first and foremost representative membership. We have to feel like every part of the newborn screening community has a voice on that committee, and there has to be a transparent process so people can have confidence that the decisions that the committee makes are appropriate. And the decisions kind of have to be consistent with broad American values. If they're not consistent with what we as a nation think is important, they're not going to last very long. So that said, how could we work this? And it's just one way of thinking about it. If this advisory committee were, as the NASEM report suggested, a much broader group, it wasn't designed to say yes or no to individual conditions on the RUS, but to think about the broad questions that you raised at the beginning. Privacy and data sorts of things. What is the true nature of newborn screening? Is it information to families, or is it really just public health emergency kinds of things? You could then imagine that the evidence review process was more like what currently happens in a lot of the genomic world. I mean, Cindy can tell you much more about what they do at Early Check or the Guardian Project, where they're able to look at hundreds of conditions and put them into different bins. And it could be that an evidence review process going forward is something along those lines, where it's the advisory committee's job to say, here's what bin A is. These are things that belong on the RUSP. Bin B is stuff that's interesting, but it doesn't really fit yet. Bin C, we need more evidence, or whatever those criteria are. And then you can sort of say, okay, here's 100 conditions. This one goes in bin A, this goes in bin B. Has this been done? So you can imagine that there is a way to move forward. It's not one condition at a time, a big vote, yes or no on each one. So I'm optimistic, cautiously, the way other members of the panel are, that we can figure out a way to do this if we're all kind of pulling in the same direction.
Great, thanks, Jeff. Megan or Cindy, any comments on that piece?
I, yeah, getting back to a little bit about genomic newborn screening, I have been involved in leading or participating in a couple of those projects. I I heard what Dr. Wendy Chung talked about before. I think, it's critically important. I'm certainly a proponent of using genomics for newborn screening. We can detect really bad conditions that we have no other way to look for, to screen for. There's no analytes available. So, using genomics is really important, but we do need to gather that data first, and we have to tread carefully about that. Um, Wendy talked about Rett syndrome, and we've also detected several cases of children, both boys and girls, with genomic changes associated with Rett syndrome and the MECP2 gene. One of them, was read as a likely pathogenic variant or mutation. And that's what we told the family. However, then when we tested other family members, we found the same variant in the father. And those of you who know about Rett syndrome, I mean, that should have been a lethal condition or something, leading to very early encephalopathy in an infant male with Rett syndrome. So anyway, clearly it doesn't look like it's really a pathogenic or a true mutation. So we just don't have enough information yet to really use genomics, in a non-consented fashion, I think. We still need a lot more research projects. And I hate to sound like a broken record, but again, we get back to funding. I do hope, NIH does fund a multi-state project to expand and do more genomic newborn screening in various states. That was supposed to start the beginning of September. It still hasn't been announced yet, so none of us quite know what's going on. But anyway, I think it's critical when you look at countries like England and the UK that are doing, a countrywide genomic newborn screening project, and they funded that. But we kind of, try to put together piecemeal, funding for these projects in the US. Our early check program will stop the end of this year because we have no more funding. It's been, quite successful. Families have been appreciative of the information that they've gotten. There's been no harmful effects that we've found in following up families. I got interested in newborn screening because of my interest in hearing loss, and I have a patient who a little infant girl who passed her newborn hearing screen, but then participated in early check, and we found pathogenic variants in a gene associated with early onset hearing loss. So because of that, she had follow-up hearing screening and was found to indeed have some hearing loss that, hadn't been present or hadn't been picked up at birth. She's since gone on to have a cochlear implant. Her speech development has picked up tremendously since her cochlear implant at a little before a year of age, I think. And her family's very appreciative to have this done. So, I'm very enthusiastic about the process of genomic newborn screening, but I do think we need to tread carefully. However, we do need a better way to review conditions to become part of genomic newborn screening, and certainly our one condition at a time, as we've done in the past, is not going to, be rapid enough to really, handle all these potentially, 100 or more conditions. But just one more thing I'll say is that all of the projects that are going on utilizing genomics for newborn screening have a different set of genes that they're looking at. Some are, have over 400 genes. Ours has about 100, a little more than 100 in our panel one. So I think there again, there's a need to figure out, which are most critical and have the best evidence. It might not be as complete evidence as we've needed before to add conditions to the RUSP, but which ones do have good enough evidence, that they're treatable and outcomes are better when the condition is detected early.
Great. Thank you so much, Cindy. Megan, I want to give you a chance before we continue down the path of genomic newborn screening.
I'm just going to go back a little bit to thinking about the criteria that maybe should be applied in the future. And I just think it's an interesting time to think about more specific versus less specific criteria. I know that that's an issue that's been discussed more locally. For us is, in a way, you can think about creating more stringent guidelines, if you will. The sensitivity of the screening test must be at least 94% or something. And in that way, you could argue that you could evaluate more conditions more quickly, and there might be more consistency around the conditions that you add. But then you might also kind of remove the ability to discuss the nuance of any one particular condition, and kind of just the push and pull of more specific versus more broad criteria, I think is an interesting topic for the future, but I don't have any answers.
And if I could just add into that for a second, because I think that's in some ways the crux of it, Megan, right? Is that those criteria, that each time there's a new committee membership, they're kind of rethinking those criteria. And it would be great, right? If that committee, that's what the discussion was. What should the criteria, what are our thresholds for these things? And then it might be a sort of a technical group that said, well, according to the committee, they say these are the criteria. So we know that these 22 fit that criteria, they're in, rather than sort of being a big debate about one condition at a time. And that way you have the debate about, well, what is newborn screening, right? Is it valuable information for a family that they could use because it might be helpful? Or do we really stick with the more traditional, which is, no parent would say no to this because it would be terrible, right? You have to treat this kind of condition. And finding that balance, that's really why you need a nationally representative group to kind of discuss that deeply.
Yeah, and just to add into that, definitely a nationally representative group, but I also think a forum that is meant for discussion, maybe heightened discussion and some debate. I think that that's also a key piece in terms of, moving these conversations forward, as opposed to saying, oh yeah, it's been 24 months, we're going to talk about consent again and say what the issues are and be like, yeah. Okay, next session, right? But a place where we really can have that active dialogue. And I know throughout the day there have been different comments along the lines of, who's having which discussions and where are the discussions happening. And we know that there are a number of different organizations who are looking at, whether it's evidence review and the processes around that and how do we maintain that moving forward. Other groups saying, how do we bring people together to talk about what does consent look like, both the actual reality and the family experience of that, as well as what could truly be implemented at the state level. And so again, really making sure that we have those opportunities to share not just what individual groups are thinking about, but sharing that out back with the public and having that more active dialogue. I'll go a little bit further now in speaking about genomics, since it's already come up in our session today, and really thinking about the role of genomic newborn screening, as some are calling it. There are lots of different ways of talking about that. And Cindy, you did such a nice job speaking to, where that is currently and some of the key issues in that space. But, I'd love to hear from the rest of our panel, really thinking about, what are the opportunities there? I think it was just this summer that there was a group based out of Florida who is speaking about being able to provide newborn or sequencing for newborns, for any newborn born in the state. At least that's what the headline was. I don't know what the reality and implementation of that is going to look like. That's not through newborn screening, but something that's going to be offered. We know at the global level, there are many, many countries who are doing this in a research venue, but really for many citizens, if not all of their newborns. And so I turn, with all of that happening now, I turn the question to you all in terms of really thinking about, where do you really see the role of genomics in newborn screening? And you can take that as public health newborn screening, or screening during the newborn period, as long as you just say which one you're referencing in that. What does that realistically look like over the course of the next 2 years, as it's something that seems to be moving a little bit out of, I don't want to say out of research completely, but being able to reach more and more people? Do I have to call? No. Jeff
Yeah.
always will jump in.
Yeah, I'm always trying to be polite and let others talk first. But I'll stall while you guys think of something good to say. How's that? Um, so my sense of this, Natasha, is so imagine you're going to have a baby, and you might be the sort of person who says, the more information I have, the better. I want to know as much as I can, and it may not make that much of a difference, or it may make a difference for my baby someday, and my family, but I feel more control over what's going on. You may also be the sort of family that says, man, I'd like the future to unfold. And having a lot of information, especially if it's not stuff I can do anything about, that just would fill me with anxiety. And it's interesting when we look at adults, for example, and whether they want to have information about their genomic future, reasonable people disagree. There's just different, some folks really like it, some people don't, and that's okay. And I think that when we start moving toward, and as you heard from Cindy, yes, there's sometimes we're pretty good, right, on the genome phenotype connections, and we probably can make good predictions. But a lot of it really is sort of unclear at this point. I would say that this is probably best done in clinical medicine, right? As part of prenatal care, let's say, or even after a baby is born, where the family can talk with their clinician, can talk with a genetic counselor, can say, here's the value, here's the risks, here's the benefits. My concern about moving too quickly into a state newborn screening place where if there is consent, it's done in the day or two after you've just had a baby, which is not a great time to be thinking about these, kind of complex questions. That would give me pause. I recognize that you lose out on making sure every family gets the potential benefit, right? When you move away from a state public health program to what happens in clinical medicine, true across the board. But it seems to me that until we have really definitive proof of any specific genomic newborn screening technique, we're better allowing families to make decisions for themselves and not get caught up in the state apparatus, which really has been shown to save so many lives. I'd hate to see that get too confused for families. So that's Jeff's 2 cents for what it's worth.
As a public health individual, as has been mentioned earlier today, when when you're talking about a mandatory public health program, I just think that bar is very high for what we're asking families to do. So I don't see a ton of appetite for replacing first-tier newborn screening with sequencing. I am very excited about the possibility of reducing false positives with a second tier, increasing that usage of DNA testing currently, and kind of investing in states being able to bring that in-house. We do send outs currently, and that can be, a 2-week wait between when a family has been notified of an abnormal biochemical screen and kind of waiting for that second tier test to come back. So I could see a lot of benefit to reducing that time or reducing calling out abnormal results altogether by the use of more DNA sequencing. But I think unless we develop a system where there's a secondary panel that's opt-in and not mandatory, it's hard for me to envision it being more widespread in public health.
Maybe I'll wrap it up by kind of coming around it from Do families really understand what this means? We are here at boot camp, right? But do they really understand the difference between when we talk about molecular testing, the whole genome sequencing, what does it mean, and how can we continue to educate? So while we're in this restructure phase of what we want to do without having newborn screening saves lives and the funding for an ACHDNC, how can we embrace education and digestible information for families to understand the importance of this because they truly are the strongest advocates for themselves. But we have to be able to ensure that they understand the language and the dialogue and they're able to advocate for it and have strong voices around this potential area of whole genome sequencing because in the end we are seeing other countries start to move in this direction. And we don't have a large database of information to say, can this be successful? And what does success look like? And so that comes back to this big important word called trust. Trust. We need to trust. And families want to be able to trust this type of process and that it's ethical and that we're moving in a way that can speed things up so we can get to the crux of why newborn screening exists. Identify an illness within a baby at birth that has a treatable opportunity for a high quality of life. But everything to get there can seem very difficult. I think we heard in one of the sessions, we all believe in newborn screening. Like, yeah, of course I believe in newborn screening. Of course I want to test my child or what this looks like. When we get into this area, sometimes our patient advocacy organizations themselves need to be leveled up, as well as the families themselves to understand what's at risk and what's at stake.
Thank you, Terry. Well, you're speaking my language when you start talking about education and communication to families and to the public. And I think a big part of education that sometimes we don't spend as much time on is it's not just what is the information we want to convey to families, but what is the information families want, right? Since the launch of Baby's First Test, the questions that we have gotten that have come in have been consistent. It is typically around how accurate are the tests and what are my next steps? Is this real? Is this real? Are you really telling me my baby might have something wrong with them or something I need to address? And so in many ways, that's where education has to start, from that lens, not necessarily just for some the excitement, for some the concern around sequencing. Moving on a bit, and incorporating some of the questions that have come in through the chat over the course of the day. So often people talk about, we need to be doing more in newborn screening, a larger scale approach to newborn screening. And when people say that to me, I always say, what do you mean by that? Very often we talk about more conditions, but I've been known to say on more than one occasion that we could stop adding conditions to newborn screening right now, and there still would be a lot of work for us to do in terms of improving the system. I'm not saying I'm suggesting that, but that is a real reality when we're looking at newborn screening and newborn screening systems. And even in the session that was just before this, in the Q&A, there were a number of different posts about, the potential opportunities for educating healthcare providers about doing maybe more appropriate call outs. How do we make sure the experience for the families goes a bit more smoothly, that they don't necessarily feel like they're getting bombarded with information that sometimes conflicts. There was someone who in the Q&A even said that they'd heard from moms who had gotten a follow-up saying, there's an out of range result, and then saying, but this happens all the time, don't worry about it. And then a couple of days later, when the diagnosis actually came, felt like they got hit multiple times, like up and down. Am I supposed to worry? Oh, I'm not supposed to worry. And then a couple of days later, yeah, of course you have to worry. This is a rare condition, right? So again, just another example outside of adding conditions where there can be improvement in the newborn screening system and in part of the system that is outside of a newborn screening program, right? In terms of the state program. So all of that to say, when thinking about larger scale improvements in newborn screening, really thinking and looking at what does that mean from the places you all stand. It could still mean, adding more conditions, and that's great. But again, because you all represent different facets of the newborn screening system, it'd be great to hear from you in terms of, what are those larger scale newborn screening improvements you would like to see in the upcoming years.
Maybe I'll go ahead and jump in. And one of the places is slightly selfish, but it's because the place that we're in currently. And that's this area that seems that can be difficult, which is, I consider it national autonomy, a state autonomy, I should say. And how do we work that with the national coordination? Because we're in a space right now where we have treatable disorders that we don't have really a mechanism to move a nomination through. And so we're getting to really ramp up our state advocacy work. But what can long-term look like in terms of having this state autonomy versus our national coordinations like we've had with Russ? Because we want to follow a federal situation. Following the RUSP was very important to us. Having RUSP alignment was very important to us in order to bring these states on and screen more babies as possible. But I want to wrap around something that has some type of ability to accompany any financial support that's going to be necessary to coordinate on a national scale so that states aren't having to work in such an autonomous fashion. And going back to what Cindy and Jeff were saying a little bit ago, because they experienced that part where there was such a discrepancy in the states of who was testing what and where at the time, 20, 25 years ago, where it was, I don't like this word, but I'll say it, but it was almost, I keep hearing it, and I just heard it last week, death by zip code, because states are just going to be at such different levels. So I want to find a way for that to work. I want to find solutions in that space.
Great, thank you, Terry.
Well, I think Megan brought up a very important thing, and that's the high bar we have to maintain in newborn screening. There's this concept of parens patriae, which means that the state, wants to protect the vulnerable population, and in this case, it's newborns, and that the state knows better than really parents do in terms of, the need to test the baby for conditions that are on the state panel. And I think, we think, it's pretty obvious, like for PKU, we know that unless that baby gets on a special diet quickly, they're going to have brain damage and, have intellectual disability long term. So we really take that out of the hands of parents. And that's pretty unique in most things that, parents are able to decide for their children. Yes, there are opt-out things in, most states, but, for the most part, parents don't even know, when that heel prick is being done, what's happening with that. So I think we do have to maintain that high bar. And that's really important as we go forward. And then something that Terry brought up earlier was trust. And I've seen, I don't know, I have concerns about changes in the trust that parents have in the public health system. I don't know whether that's coming partly from what's going on with vaccines, but, we've experienced recently some parents with, baby had a positive screen and they really don't want anything more done because they really don't believe what we're telling them. And I'm really concerned about that. So I think we have to, as I said, tread very carefully in this arena, keep our high standards, and maintain a trustworthy system.
Go ahead, Megan.
I'm thinking about that might be important for the future is just building in flexibility and multiple pathways. I know in my local area, so while we did become quasi-RESP aligned, we did also simultaneously maintain our petition process. And I think recently we've been grateful for that flexibility since when folks come to us interested about adding a condition, we can still direct them to that pathway. And even if things slow down on the RESP end, there's alternate ways. And similarly, I think about there is some criticism about having individual state review process, about kind of the duplication of efforts and the increased time. And that's where, even though we were doing our own individual review process, we really relied heavily upon those federal evidence-based reviews, particularly for data, since the data needed for newborn screening, I just think is unique. And oftentimes I'm trying to like parse out individual data points from other publications, and it just doesn't work as well. So I think kind of the different collaborations between resources at the federal level and the state processes, just kind of having multiple pathways and flexibility going forward might be a benefit.
Just a couple quick ideas about what else, when we talk about newborn screening and the bigger pieces, and you alluded to this, Natasha, is that long-term follow-up. I mean, sickle cell disease, we're very good at identifying, and still fewer than half of those kids get clinically based guidelines, fulfilled. And our healthcare system is just, some kids get better access to care than others. So I think that's one thing that we are all of us still working on. It may be something a little bit different too about how we might get to decisions about what newborn screening should be. And Natasha, you talked about having really good, free, open debate, among whatever this new advisory committee is. We also can do research to kind of learn more, right? And there are ways that you can do, citizens juries or participatory democracy, where you gather sort of a random sample of human beings in the United States of America, and they spend some time really learning about the issues. What is going on in newborn screening? Here are the privacy issues. Here are the consent issues. Here are the things like, how much should we spend on this, right? How much of our state, apparatus should be based on newborn screening versus other things that we do? What are the opportunity costs? And I think it would be really helpful to get that kind of research, that evidence to say, we as a nation really want to invest a whole lot more in this. We think this is really important. We're less worried about privacy. We're more worried about babies dying, or vice versa. And so it's not just the few lucky people who happen to be on the advisory committee deciding for the whole nation, but it's informed by a broader process that says, what truly are our values as a nation? What do we care about? What's important to us? And then we can implement that policy. I would really love to see a little bit more of that kind of work. Thanks.
Great, thank you. I would like to say just thank you to this panel, and thank you to all of you for answering these really big questions that don't necessarily have one set answer, but also bringing a real level of optimism and, dare I say, hope in this discussion, and that we can do it, and that it will take effort to really envision what's next, but it's not necessarily envisioning something that's super far away. We are already envisioning and enacting in many ways already. And I think that shows that there will continue to be momentum and movement within a newborn screening. So thank you very much to this panel. And as we come to a close for this meeting, I want to say first thank you to all of our participants and the questions that were shared that helped keep the dialogue going for our different panels. I'd like to also say thank you to all of our panelists from today for sharing your insights and your experiences in newborn screening, and really laying out, what the next year, 2 years, 3 years may look like. And of course, on behalf of both Expecting Health and the Every Life Foundation, saying thank you to our sponsors for this year's boot camp and allowing it to continue. We know that there are so many great connections that come out of the boot camp. We hear stories every year and hope to hear the same thing this year. And that is done by all of you as participants, as well as our sponsors contributing to this day today. So with that, I think I will close out the meeting and wish everyone a great rest of the week. Thank you so much.
Bye, everyone.